To chair this talk, I call Dr. Nirmal Kumar sir, Dr. Rajesh sir and Dr. Ravindran sir on stage.
இதில் வைக்கலாங்க வைக்காதோ சரி மாட்டேன் குட் மார்னிங் இந்த மணி ஃபேன் வைக்கிறீங்களா ஆ
Good morning, everyone. I thank the organizing team for giving me an opportunity to stand before you. First topic will be the anatomy for dissection planes and nerve preservation in TME and CME. So first, before into the details about the facial planes, first we must know about the variations in the anatomy of the colon. Colon is supplied by the artery of the midgut and the hindgut, that is superior mesenteric artery and the inferior mesenteric artery and its vein. So some variations in the right side of the colon is always there. So it is branches of the superior mesenteric artery, say iliocolic artery and middle colic artery and right colic artery. Sometimes from the origin, the iliocolic artery from the superior mesenteric artery, it comes posterior to the superior mesenteric vein in 80% of the cases, and rest of the cases it comes in front of the, so it is very useful. You have to be care when you ligate the CVL, that is venous artery ligation. Then middle colic artery, it sometimes it has two branches and sometimes it is completely absent in 25% of the cases, and in 10% of the cases there may be accessory or double middle colic artery. Right colic artery, sometimes it arises from the iliocolic artery or the middle colic artery. So topography of the iliocolic artery and right colic artery in relation to the superior mesenteric artery is important for the vascular ligation. Coming to the inferior mesenteric artery, it's artery of the left-sided colon. It arises a direct branch of the abdominal aorta, 3 to 6 cm above the aortic bifurcation. It has three branches, left colic, sigmoidal branches and the superior rectal artery. Coming to the venous anatomy, it highly variable from the arterial structure. So variations in venous anatomy to be understood to prevent injury during complete mesocolic excision. So first one is the gastrocolic trunk of Henle. It is formed by the confluence of right gastroepiploic vein, superior right colic vein and superior pancreaticoduodenal vein. It is present in 40 to 70% of the cases, may be spared even with tumors in the transverse colon. So variation, right colic vein drains 56% of the cases drains into the superior mesenteric vein and 44% of the cases drains into the gastrocolic trunk. Middle colic vein also 85% in the superior mesenteric vein, rest in the gastrocolic trunk. Left side, the superior rectal vein continues as inferior mesenteric vein drains into the portal vein with sigmoid and left colic branches. So damage to the superior mesenteric vein remains the biggest fear, occurring up to 1 to 6% of all the surgeries of the right-sided colonic lesions. Sometimes excessive traction during the surgery by the hepatic flexure may also lead to avulsion injury of the middle colic vein. Usually its origin from the superior mesenteric vein. Coming to the nerves and lymphatics, it has splanchnic nerves, they are third autonomic nerves. It has motor and sensory. Motor are efferent and sensory is the afferent fiber. Damage during radical lymph node dissection. So lymphatics, it is epicolic, paracolic, intermediate and central. Epicolic and paracolic comes under the pericolic lymph nodes. Intermediate nodes lies along the trunk of the named vessels. The central vessels along the main vessel, that is superior mesenteric artery and superior mesenteric vein and aorta. So what is height I? Central ligation of feeding vessels at the origin of the superior mesenteric artery and superior mesenteric vein to include the D3 lymph nodes in complete mesocolic excision. So what is complete mesocolic excision? This dissection between the mesenteric plane and the parietal fascia to remove the mesentery with a complete envelope of mesenteric fascia and visceral peritoneum so that it contains all the lymph nodes draining that area. And it has three components. Second one is the central vascular ligation to completely remove all apical lymph nodes which lie along the major vessels. And resection of an adequate length of the bowel to remove the involved pericolic lymph nodes in the longitudinal direction. So complete mesocolic excision has three components: dissection in the embryological plane, central vascular ligation, and resection of the sufficient length of the bowel. So this is the resected specimen. So C is the length of the colon, A from the tumor to the vascular tie, and B is the closed distance of the lumen bowel from the vascular tie, and the D denotes the complete mesocolic excision, that is a mesentery. So length of the bowel, area of the mesentery, and closest bowel wall to high vascular tie, and distance from the tumor to the high vascular site. This is the ideal specimen when you do complete mesocolic excision, that is radical surgery for the cancer. So to conclude in complete mesocolic excision, the specimen should have an intact mesocolon on both the sides, no defect in the mesentery, and pathologist should be able to measure the distance of the tumor to the highest vascular tie. Coming to the surgical anatomy of the mesorectum, that is total mesorectal excision, that is a removal of the rectum along with the surrounding mesorectum which contains the fatty tissue and the lymphovascular structures. That is the holy plane, refers to the specific facial plane of dissection between the visceral and the parietal fascia. So it says dissection along the embryological planes of the dorsal mesentery and complete removal of the rectum along with the mesorectal envelope. So anatomy, it is surrounded by a fatty tissue complex called the mesorectum which correspond to the mesentery of the rectum, and it contains the blood vessels, lymphatics and lymph nodes, and it is enveloped by a thin fascia, that is visceral pelvic fascia. So dissecting the correct anatomical plane can lead to good oncological outcomes and preserve the autonomic nerves to prevent postoperative urinary, sexual and defecatory dysfunction. So rectum and the mesorectums are developed by the enveloped by the fascia propria of the rectum, which is also called as the mesorectal fascia. This fascia is correspond to the visceral fascia of the rectum. So this visceral fascia of the rectum, caudally it ends at the internal sphincter and laterally it ends at the internal iliac artery, and it is connected to the parietal pelvic fascia. So the presacral fascia is called as parietal pelvic fascia. It covers the anterior surface of the sacrum and encloses the sacral vessels and the nerves. It combines at the level of L4 with the mesorectal fascia to form a part of the anococcygeal ligament at the level of the anorectal junction. So dissection between the visceral and the parietal pelvic fascia at this level may prevent injury to the major vessels in the sacrum and preserve the functions of the nerve. The presacral venous plexus is formed by the two lateral sacral veins, middle sacral veins and the communicating veins. These plexus runs underneath the presacral fascia. So these presacral fascia may be damaged during posterior dissection in a deeper plane. So life-threatening massive bleeding can occur and it is very difficult to control. So dissection should be between the parietal fascia and the parietal and visceral layer, that is between the mesorectal fascia and the presacral fascia until the rectosacral fascia is encountered. So this is the diagrammatic representation. The fascia propria of the rectum covers the rectum and the mesorectum. The presacral fascia covers the anterior surface of the rectum. So it combines with the fascia propria of the rectum at the level of the X4, form the level sacral vertebra to form the valgus fascia. Tirunelveli fascia is the dense membrane between the rectum and the seminal vessel. This is the anterior layer and that is the posterior fascia. So this diagram shows the rectosacral fascia which lies in the posterior dissection, comes in the posterior dissection. Tirunelveli fascia, the dotted yellow line shows that's a plane between the seminal vesicles and the rectum. If it is in the correct plane, no injury to the vessels and the nerves, otherwise there will be bleeding and injury to the nerves. In female, the rectovaginal septum between the vagina and the rectum. So, in surgical plane for low-lying rectal cancer, you must be careful. Make sure you are in the correct plane between the parietal and the visceral layer in order to avoid injury to the sacral plexus and the nerves. This is the diagram showing the intersphincteric resection in the low anterior resection. So, pelvic anatomic nervous system, it consists of superior and inferior hypogastric plexus. The superior hypogastric plexus is formed by the sympathetic nerves from T10 to L3. It forms a dense nerve plexus at the level of L5 and it bifurcates into the hypogastric nerve at the level of the sacral promontory. This superior hypogastric plexus comes around the inferior mesenteric artery, so it may be damaged when you go for vascular ligation, central vascular ligation as the inferior mesenteric artery in a case of left-sided colonic lesion. Injury to these nerves result in the retrograde ejaculation and urinary incontinence. And it comes as hypogastric nerves when it crosses the left common iliac artery at the level of the first sacrum and descends into the pelvic cavity along with the left pelvic wall, lateral pelvic wall. This diagram shows the hypogastric nerve. Then pelvic splanchnic nerves, these are all the parasympathetic nerves, arises from the second to fourth sacral spinal nerves. It enters the pelvis through the sacral foramen, posterior to the parietal fascia to enter the visceral compartment and 4 cm from the midline. Small branches of the pelvic splanchnic nerves run medially and enter the mesorectum. These nerves may regulate the emptying of the urinary bladder, so injury to the nerve may also lead to some disturbances. This is the diagram showing the pelvic splanchnic nerve during the dissection. Then inferior hypogastric plexus, the pelvic splanchnic nerves meet the hypogastric nerve and form the inferior hypogastric plexus as the lateral pelvic wall. It lies outside the fascia propria in the superficial layer of the parietal fascia. The inferior hypogastric plexus can be observed as a mesh-like structure at the posterolateral wall close to the prostate and the seminal vesicle. Then inferior hypogastric plexus consists of both sympathetic and parasympathetic fibers. Damage to these plexus may result in urogenital and sexual dysfunction, and it extends forward to form a neurovascular bundle along the seminal vesicle. So these neurovascular bundle continue to form the periprostatic plexus which supplies the prostate, seminal vesicle and corpora cavernosa and the vas deferens. So injury to these structures may occur if you go in a wrong plane. So medicular dissection is required because nerve damage may occur during surgery when you enter the long plane or excess traction is performed. This diagram shows the inferior hypogastric plexus. So what are the sites in which injury to the nerve can occur? The superior hypogastric plexus, it is mainly by the sympathetic fibers T10 to L3. Site of injury in IMA ligation, effect ejaculatory dysfunction, urinary urgency and incontinence. And hypogastric nerves, continuation of the superior hypogastric plexus, enter into the site of injury into the pelvis or polyplana herald. And pelvic flanking nerves, parasympathetic nerves formed by S2 to S3 nerve, and common site of injury, lateral and posterior dissection. The inferior hypogastric nerve, it is mainly of parasympathetic and sympathetic nerve, injured during the lateral dissection. So to conclude in total mesocolic excision, identify and preserve the autonomic nerve in order to avoid postoperative urogenital dysfunction, not to damage the superior hypogastric nerve during IMA ligation, not to damage the pelvic plexus during posterolateral pelvic dissection. During anterior dissection of the rectum, it is important to perform meticulous dissection and not to injure the small numerous neurovascular bundles in the 2 and 10 o'clock directions of the seminal vesicles. Thank you.
Thank you. Thank you, ma'am. That was a
presentation regarding the anatomy.
the emphasis on the applied anatomy and components of CME you have beautifully brought out. And so.
Very glad I have gone through a meticulous dissection in this hall. It is as though we have seen a dissection. Good.
Any questions from the audience? Thank you, ma'am. Thank you.
Thank you very much, ma'am, for an insightful, thought-provoking session on dissection plates and nerve preservation in total mesorectal excision and complete mesocolic excision. Now I request Professor Dr. Ravindran sir to felicitate our speaker, ma'am. Now I request Professor Dr.Prabhakaran sir to felicitate our chairperson.
fix it.
Now to help us unravel the complexities of hereditary cancer syndromes, germline mutation and genetic maker, which forms the potential role in predicting cancer risk and guiding screening strategies, we welcome Professor Dr. Alex Arthur Edwards, Professor of General Surgery, Sri Mukabika Institute of Medical Science, to give talk about genetic testing in colorectal cancer risk stratification. To chair this speech, we call upon Professor Dr. Velladuruchi Madam, Professor Dr. Rafiq Sir and Professor Dr. Sivanapanian Sir on stage.
Warm good morning to all of you, and my profuse thanks to the organizing team, especially Dr. Prabhakaran sir, for making me to read this topic. The PG Banbodi, this topic never read. The Ragesh Sivanu, I was talking to Sivanu, Dr. Sivanu, but this is a topic which we usually skip. But I think lot put on the so Prabhakaran sir, I read about this. Okay. Right. So why colorectal cancer is risking throughout the ages? The thing is, now we have got more of sporadic forms of colorectal cancer. But in fact, we are treating the patient sometimes. Sometimes there will be over-treating. Sometimes there will be under-treating. Sometimes there will be no treating. So the thing is, the mortality rate now, they state it's about 65%. 65%. So, therefore, we need a robust risk stratification so that we will identify the cases early. Am I audible?
Yes, sir.
So the concept of risk stratification, now this has dramatically increased the screening. Now we do colonoscopy every 1 to 2 years, starting much younger. That is about age of 20 to 25. Now they tell about 16 years, sir, Jaswan sir. So FAP, they now the mean age group is 8 to 34. Now they are doing at the age of 16. So we have a plans of prophylactic surgery. So I have some doubts about that to Jaswan sir about FAP prophylactic colectomy. Then extra colonic surveillance, right? In Lynch syndrome, we'll have to screen for endometrium and ovary, and for FAP, we'll have to screen thyroid. Then there is a thing called the cascade testing. Risky individuals will have to do the testing. Then this you all know, these 5 types of polyposis. So the main polyposis is adenomatous polyposis, that is FAP. Then familial adenomatous polyposis, there are 6-7 types. Then attenuated type and MUT-A associated polyposis. Then MH, these are all the DNA damaged genes. Then polymerase proofreading associated polyposis, then axin associated polyposis and NTH. So this is about adenomatous polyp. Then coming to the serrated polyposis, then serrated polyposis syndrome and non-polyposis in the Lynch. So even though Lynch is, it tells us non-polyposis, so the meaning is there may not be no polyps, not like that. Polyps will be minimum. Then comes the hematomatous polyposis. There are three syndromes. One is Cowden, then another one is juvenile polyposis, then Peutz-Jeghers. This we all know that. Then there is a mixed polyposis, the combination of adenomatous and hematomatous. There is a hereditary mixed polyposis syndrome and Cowden syndrome. So as we all know, the common genetics of colorectal cancer, 70% sporadic. Only we are bothered about the 30%. 70% we can't do anything. There are so many factors being postulated. But in the 30% we are bothered about that. Then they have inherited syndromes like germline mutation, then polyposis syndrome we have got 3, FAP, then multipolyposis and hematomatous polyposis. Then hereditary non-polyposis colonic cancer, then familial colorectal cancer. Then we have got the syndromes, they are from the adenomatous polyps, from the serrated polyps and from the hematomatous polyps. So this muti is nothing, I think you all know, it's a DNA mismatch. It's a DNA mismatch. There is a problem with the DNA synthesis. Then there is a stage at which there is a glycolysis is being affected, and there is a mismatch. Puranda the jodi, adenine and guanine, they have got a mismatch. So this is a problem with the mismatch. That's a muti. Then serrated polyps, you have the gene not yet known. Then you have serrated polyposis syndrome and hematomatous polyp. Then I have already told about the juvenile polyposis and Peutz-Jeghers and Cowden syndrome. Then I think you would have read about this adenoma carcinoma sequence. So here again what happens, everything goes on to the DNA synthesis. So there is two things, two assaults are happening over there. This is a normal mucosa, we have got a submucosa and the muscularis propria. And when there is a germline or inherited and or somatic mutation, there is a cancer suppressor genes are mutated. That is one assault or one injury. The other thing is the second hit or second assault is a methylation abnormalities which happens in the DNA synthesis. So this evaluation of KRAS mutation proto-oncogene, then homozygous loss of additional cancer suppressor genes at P53. It's a very dangerous proto-oncogene P53, and additional mutations they produce the carcinoma. So there's a normal mucosa becomes adenoma, then to the carcinoma. This is adenocarcinoma sequence. So this people talk much about the molecular pathways in colorectal malignancy, like what do you do in a breast malignancy, luminal and the mari classification, I think not yet published. They are more in favor of now, apart from the genetic this thing, they are evolving with molecular pathways in colorectal malignancy. So here there are three pathways postulated. One is the chromosomal instability, there is CAN, another one is microsatellite instability, and the third one is serrated pathway. So all the adenocarcinoma sequence, then producing colorectal cancer, and you have got Williams syndrome and the MLH1, these are all misplaced DNA genes. So deficient mismatch repair, that is MMR producing colorectal cancer, and then finally we have got the methylation pathway problem ending in a colonic cancer. So these are all the three pathways, the molecular pathways in colorectal malignancy, and the PG should know about that. You may be asked. Then this is a universal Lynch syndrome tumor testing. So you have operated a case of colorectal malignancy and you send the specimen for two things. One, MSI testing, instability testing, another one is IHC. So when the MSI is normal, then no further testing is needed. So if it is high, then you have to do IHC, immunohistochemistry. Then there is a loss of MLH and PMSSY, then we will have to send it for BRAF. That BRAF testing, if it is positive, then there is no need for further evaluation. Then if it is negative, there is a patient, you have to send for MLH promoter hypermethylation, and you have to send him for genetic counseling. So there is a loss of other MMR proteins also. You will have to send the patient for counseling, genetic counseling. So nowadays we are in the era of giving counseling for the patient, first degree relatives and second degree relatives, and especially in FIP and other related things. Then you all should know about KRAS. You all know that what is KRAS? What is KRAS? Full form. Anybody? Kristen? Rat? Sarcoma? Antigen analog. That is KRAS. You have got HRAS, then you have got NRAS. This KRAS is very important. And the mutation of KRAS leads to proximal colony cancers, which is due to continuous G cell protein activation causing, you have got a proliferation, multiple proliferation of G cells producing malignancy. You have got multiplication. So what is the significance? The significance is, so this is a routine evaluation in stage 4, then fecal colorectal cancer screening, this is used, then resistance to anti-EGFR drugs, then finally future therapeutics. So that is a thing about that. And usage of KRAS genetic analysis on treatment of metastatic. So what about metastasis? Same, you send the sample for study, then you got KRAS mutation. If it is positive, then the prognosis will be very bad, the KRAS positive. Then you got negative, you send the patient again for BRAF mutation. If it is positive, and EGFR therapy, and it is negative, and therapy is indicated in negative and not indicated in positive. So this we all know is FIP, adenomatous polyposis syndrome. This is an autosomal dominant variety, nearly 100% penetrance with more than 100 synchronous colonic polyps. So there will be more than 100. So the adenomas have higher potential to turn into malignancy, occurring mostly in the middle-aged individual. And the germline mutation with the APC on chromosome 5q, inheriting one damaged allele is enough. See, one allele, if it is damaged, then that will progress on to formation of mutation and formation of malignancy. There are two variants, one is AFIP and another one is muti. Only the muti varieties are autosomal recessive, others are autosomal recessive, and others are autosomal dominant. So these are all the differences between Lynch syndrome and the familial adenomatous polyposis. So coming on to the pathology, pathogenesis is a microsatellite stability. Microsatellite instability is nothing but the small, like a receptor sites, it will be very small. So there is a micro, will be situated on the surface of the DNA. So producing, so any problem with that small assault produces instability, later on leading on to a Lynch syndrome. So then familial adenomatous polyposis is a chromosomal instability. Then inheritance is autosomal dominant, 80%, that 100%. And the age of onset is 44 here, around 44 mean. Then FIP from 8 to 34. So that's why the screening now starts at the age of 16. So 90% of these individuals, say FIP, will develop colorectal cancer at the age of 45. So you have to be specially concentrated on this group of individuals. So polyps, you don't see much, but here it's many. Then typical tumor characteristics, this will rapidly convert the polyp to cancer, then this right-sided mode, but there slowly converting polyps. So it degenerate to fibrous and bowel constricting tumors, more of obstructive pathology. So why the need and want of genetic testing in the recent times? Then whom to test? So we have to do a personal history, early onset of CRC, there is less than 50 years, there are multiple CRCs, so MMR, there is a DNA mismatch genes related tumors, then specific polyposis, there is more than 10 adenomas, fluoroscopy, then hematomas and serrated polyps. when you give the family history, then multiple relatives with colorectal carcinoma, Lynch syndrome and known familial mutation. When tumor characteristic, M.Uma and M.S, these are all the DNA synthesis problem, genes with produce specific histology. Then coming on to genetic testing, it is fundamental to modern colorectal cancer. It effectively classifies individuals into 4 categories. One, very high risk individual, that is hereditary syndromes. They require aggressive, early and specialized management. These particular people will have as early as possible, they will have to do the proper screening. Then high risk coming, these individuals will have a family history. On average risk, follow the population screening guidelines. So the fourth one is a treatment guideline. So what targeted treatment can be given? That is anti-EGFR treatment and immunotherapy, and this will predict the prognostic value. So what are the recent advances for PGs? There are 2. So what are the factors that we use for risk stratification? One, age. Number 2, family history. And number 3, genetic predisposition. Then number 4, lifestyle factors. Number 5, prior screening history. And what are the recent advances? So multi-omics. What is omic? Genomic, proteomic, like that. All omics. Then omics analysis and artificial intelligence. Now every field has got artificial intelligence and genomics, next generation sequencing, all these things have come. So now the staging and all, what we follow now is PTNM or CTNM, all is slowly vanishing. Now we are going on to the molecular staging. So treatment, everything based on the molecular staging. I think in the another 2 years when we conduct another CME, we will be talking about molecular staging and molecular treatment, like what do you do in a breast. So artificial intelligence has got a vital role nowadays. So there are 2 widely accepted models. One is Pianos model, that is platform independent and normalization free single sample classifier. And that is, with a single modality, we classify everything, all omics, like genomics, transcriptomics and proteomics, to identify the basis and patterns of biomarkers associated with the different risk groups and treatment responses. So this is an independent predictor for a disease-free survival. And another is a Miscan model, Miscan colon model. This is a simulation model. So now here they use artificial intelligence more. So we have got 2 models, and I would like to tell something about the screening options. So I will take another 5 minutes, sir. 5 minutes. Right. So screening options are annual fecal occult blood test or fecal immunochemistry test. That is annually we will have to do. Then stool DNA test every 3 years. Then flexible sigmoidoscopy every 5 years. And colonoscopy every 10 years, and double contrast barium minima every 5 years. Now, I think we are not doing probably contrast, barium contrast. Which centers and all doing or not, I don't know. But in our institution, we do double contrast. So then CT colonography every 5 years. Then this, you spend at least 2 minutes with this slide. This is a very important one. This is a familial risk category. That the colon cancer surveillance recommendation is recommended by Colon Cancer Society. So the recommendations are first degree relative affected with colorectal cancer or an adenomatous polyp at the age of 60. 60 is a cutoff line. So 60 years and older are 2 second degree relatives affected with the colorectal cancer. We have to do a same risk strategy starting at the age of 40. Right. So most of us come under this thing. Then another next one, 2 or more first degree relatives with colon cancer or a single first degree relative with colon cancer or adenomatous polyps diagnosed at the young age, that is less than 60. So for them, we'll have to do colonoscopy every 5 years, beginning at the age of 40. are 10 years younger than the earliest diagnosis, whichever is early. So whichever comes first. Then third one second degree or any third degree relative with colorectal cancer. We will have to do same average risk. Then fourth one, you look at that, this is a very important thing. The gene carrier are at risk for familial FAP. FAP you will have to do sphygmoscopy annually beginning at the ages of 10 to 12 years. So because the mean age group of occurrence is between 8 and 34. So that finally gene carrier are at risk for HNPCC, colonoscopy every 1 to 2 years beginning at the age of 20 to 25 or 10 years younger than the earliest case in the family, whichever comes first. So this is my last slide. So in this modern era, so the integration of tumor testing, the MMR, MSI, RAS, RAF, everything, and germline testing within a framework of clinical criteria, then family history and genetic counseling provides the most comprehensive approach to CRC risk stratification and personalized management. So BRAF600E mutation gene is common in a sporadic case, and finally the P53 has got a worst prognosis. Thank you for your patient hearing, and thank you for making me read for some days. Thank you. Srinivasan, thank you. I thank the chairpersons. Thank you, sir.
You have read a lot, sir. Now, I request Dr. Armugam to give more input so that the audience can get some more in a simpler way.
Thank you, sir. It's an extensive presentation. We also learned some points from your presentation, sir. For the hereditary colon cancer, we are seeing most of the patients with the AFP and HNPCC, Lynch syndrome. So, other genetic diseases are less common, and also hereditary colon cancer in per se, the percentage is less than 10%. So, the colonoscopy guidelines and everything are mentioned here. So, first degree relative with colonic cancer, we have to start with the colonoscopic annual screening from 40 years of age. Otherwise, this HNPCC and this is APC, we have to do it a little earlier. So otherwise, for the treatment, in the treatment aspect, we are bothered about these KRAS, NRAS, BRAF mutations, and also this MMR and MSI. So these are the things are now playing main role in the management also, sir.
The main aim of the stratification is to bring down the mortality from 65 to 85, 65% to 85%. So that they are working.
Yes, sir.
Thank you, sir, for a very exhaustive presentation. You made a very complex topic into a very simple one for us. Thank you, sir. Thank you.
Questions? Thank you, sir.
Thank you, sir, for enlightening us deeply with the remarkable session on genetic testing in colorectal cancer risk stratification. Now I request Professor Dr. Sivanapaniyan, sir, to honor our speaker. I request Professor Dr. Prabhakaran, sir, to come on stage to honor our chairpersons.
we welcome Dr. Jaswant sir and the UP Srinivasan sir for the meeting, sir. Sir, and also the Padmanabha sir for the meeting, sir.
Now we request Professor Dr. Karthikeyan ma'am, Professor Dr. Rani ma'am and Dr. Sasa sir to chair this session. Imaging is not just a tool, but it's a strategic guide. It determines how far the disease has progressed and helps in staging and management. To shed light on this vital topic, we are privileged to welcome Professor Dr. Jayalal, HOD Department of Surgery, Kanyakumari Medical College, on stage.
Good morning and welcome to this session. I am extremely delighted to be with you at this moment. Especially my greetings to Professor Dr. Saravana Bhoopathi for that. It's one of the great achievement in the government service that we are reaching up to the level of the superannuation. So thank you very much. I am so also thanked for the department for organizing this wonderful program on the colorectal malignancy. We know that initially we heard about the colorectal malignancy and the various other factors. I am not going into the details of this, but the role, my topic today which we are going to discuss about will be the imaging key roles for the imaging which is important in the preoperative staging of a local regional, the preoperative imaging is the topic which we will be discussing at this moment. Why do we want to do preoperative imaging? For the various reasons. One of the most important thing is the local regional staging. What we mean by local regional staging, where we are going to decide about the T staging, which we know that the stage at the T of the tumor stage we are going to see, and evaluate the N stage. The most importantly, the circumferential resection margin and the extramural venous invasion. These are the two terminology which we need to know about whenever we are planning for the surgery on the colorectal malignancy. The one most important in this is the circumferential resection margin and also the extramural venous invasion, where we are going to talk about the invasion into the venous system. So when we talk about the local regional the staging, these two important roles which plays. And second is the local regional lymph nodes, and what level of the lymph nodes we call it as a local regional, especially when you take into the terms of the rectal carcinoma, the mesorectal the superior rectal and inferior mesenteric nodes, especially the nodes which are superior to the take-up of the left colic artery, internal iliac and obturator lymph nodes, provided if the lesion is above the dentate line. If the lesion is below the dentate line, even the internal nodes also considered as the locoregional nodes. So starting from the superior rectal nodes up to the internal nodes, which is below the, if it is a dentate line, we call it as a locoregional. So any nodes which are far and beyond this is going to be the metastasis nodes. If you see this, if the locoregional nodes, if it is other nodes, it's the common iliac nodes or the external iliac nodes, they call it as metastatic nodes. If the lesion is above the dentate line, the internal node will be also the metastasis. But if the lesion is going below the dentate line, the internal nodes becomes the locoregional nodes for this. The second important thing is, apart from the locoregional node and the locoregional staging, is a distant metastasis. Colorectal malignancy is known to have the lateral metastasis very commonly to the liver and the lung, but very rarely to the brain and the other part of the skeletal. So we need to understand and what are the areas of the distant metastasis. That is the preoperative imaging is mandatory to see to that. And it is also important that how far this the penetrating into the other structures, so that whether we are going to plan for only the surgery or whether we are going to add any other modalities of the treatment has to be there. And there is a second part. The third is important for the preoperative imaging for the deciding about the treatment planning, whenever they are going to talk about the upfront surgery or we are going to talk with the adjuvant chemotherapy. So this is the third component which we need to see when we do the preoperative things. And for the preoperative imaging, there are a lot of we have modalities are there, which all of you know. I am not going to the much details of this. The tomography or the colonography using the computer using, and MRI imaging. There is a lot of changes in the concept which we are going to see, which we are going to select. We will be discussing it a little later. And the PET, the role of PET and what is the role the PET is going to do. One of the most important, especially when we talk about the rectal carcinoma, is the endo-ultrasonogram. There is a endorectal ultrasonogram which is going to play a major role on the plan. So endo-ultrasonogram is very important tool which is going to be there in the rectal carcinoma, where we are going to be able to differentiate whether it's a T1, T2 tumors from the T3, T4 tumors, and this will give us a value, and whether it is going to be the locoregional or whether it is extensively it should be understood by the endoscopy. Because the endorectal ultrasonogram will give all the layers can be visualized, whether it is lamina propria is involved, if the muscular layer is involved, which can be seen. Similarly, there is a anal ultrasonogram which will be able to tell us whether it is a sphincter complex is involved, whether it is a seminal vesicle or is it, then what is the level. So one of the equipment which we are going to use in a rectal carcinoma is a endorectal or endoanal ultrasonogram is going to be used for that. CT colonography is one of the new modality which is being used more than the CT, because the CT colonography will be able to done in the contrast enhanced CT, which will be able to give us the accurate T staging. One of the most important component which is now coming down is a dual energy CT with an iodine mapping. This is a high and low level, two levels of the radiation is given, depending upon the iodine and uptake. Using the dual energy CT with iodine mapping, it will be very easily we will be able to make how much the invasion is taking place and invasion is done, it can identify. There are a few controversies there. Is it necessary to do the absolute CT chest for all the colorectal cancer? The answer is absolutely yes. The CT chest is mandatory for all the CT colorectal cancer. But one thing we need to be very careful when you are taking a CT, even a small nodules in the lung can be visualized. And if the nodule is less than 1 centimeter in size in the lung, in the CT, invariably they are benign. And if the less than 10 millimeter or the 1 centimeter nodule which in the CT lung which we are going to see in a colorectal malignancy is not necessarily to be a malignancy. Most probably it will be a benign. And if it is more than 1 centimeter or 10 millimeter, probably if you have a doubt, then we can go for the PET, and PET will be able to confirm whether the finding whether it is a lung nodule. So the CT test is mandatory for the colorectal malignancy when we are doing the preoperative imaging. And CT of the abdomen with with a contrast enhanced CT abdomen is also necessary because we are going to assess if there is any tumor markers in the liver. The most abdomen and pelvis intravenous contrast recommended to assess the presence of liver metastasis, which will be, and also not only the number of liver, which lobe is involved, the size, all that will be also assessed whether we are going to do for the simultaneous tumor resection for that. And whether it's a oral contrast is needed for the CT. And again, it depends upon which stage of the tumor which we are doing. If it is a tumor is only the T1 stage, and there is no need for doing a oral contrast for the CT. And but the tumor is more than T3 and T4, and the possibility of the peritoneal met is more, and then it is, even though it is difficult for the patient to take the oral contrast and do the CT, and it is mandatorily required, and when the stage tumor is in T3, T4. MR, what is the role of the MR? The recent concept which goes more in favor of the MRI scan than the CT, and the CT MRI is going to take over as the first line of treatment for the malignancy. In a preoperative planning, there are two important things which is most important. One is the total mesorectal resection. This is the new concept, so that the mesorectum and how far the mesorectum is involved and what is the peritoneal reflection area, that we need to study. Second is the concept of the neoadjuvant chemotherapy. So far it was thought that in the colonic malignancy always it's upfront surgery. There is no neoadjuvant role. But now it has been well proved by one of the study which is done, the Foxtrot trial, which contains the more than a huge number of patients are included, which has proved there is a role of neoadjuvant therapy in a colonic malignancy. Even for the postgraduate, when normally we teach that there is no neoadjuvant therapy for a colonic malignancy. It is only upfront surgery or upfront adjuvant chemotherapy. But now the concept of the Foxtrot trial has established that the neoadjuvant therapy has a major role both in the rectal and colonic malignancy. So now all the investigation, preoperative planning are importantly involved in understanding for what stage and to what that we need to give a neoadjuvant therapy. So its extensive planning is important. And few important words which in the planning of the preoperative planning for the colorectal malignancy is, one is the mesorectal fascia or the CRM, the circumferential resection margin. Second one is the tumor involvement in the extramural venous involvement of the tumor, and the tumor deposits and tumor buddings which are present there, and infiltration of the, whether it is the anal sphincter or the lower anal sphincter is infiltrated. So this is necessarily we need to understand before we take and plan for the surgery. So for this, the higher investigations are important, and also the appropriate preoperative the investigations will tell us whether this patient comes under the high risk, intermediate risk or the low risk, and depending upon the treatment also differ for that. If the upfront surgery in the low risk patient, there is no need for the neoadjuvant therapy is needed. But if it is and what kind of combination chemotherapy you are going to use, or whether you are going to use a short-term therapy or the long-term radiotherapy. So all this can be decided by the preoperative planning. And this is again one of the most important few words which quite new or which is very pertinent to the colorectal malignancy. One is the circumferential resection margin, distal resection margin, distal mesorectal margin, and the mesorectal microfoci, tumor budding, and this we will be discussing a little later. So one of the first new concept which understand is MRI is the primary modality of the treatment investigation for the rectal cancer, and it was generally, though we see that the CT is the robust investigation which has to be done, but now the important is emphasized on the MRI as the primary modality of the rectal cancer for understanding the T-staging, the mesorectal fascia involvement, and circumferential resection margin, which has to be will be demonstrated by the MRI scan. So I will come to that EMB later.
And similarly, the preoperative planning, preoperative imaging is important when we are establishing the patient on the putting on the chemotherapy, and how to assess the patient is the response is good or not. So depending upon the response, the residual surgeries we are going to do. So the restaging and assessment of the response also, the preoperative investigations are very important. It is also true for the local staging of the colonic carcinoma. When you talk about the colonic malignancy also, the initial, we thought it is the CT scan is good enough for doing the intra-abdominal malignancy of the colon malignancy, but the evaluation of the infiltration into the identifying the high-risk patient, especially the patients who are T3C or T3D or T4A patients. For those patients, definitely they need the neoadjuvant chemotherapy. So to the level of understanding the infiltration into the serosa, or whether there is how much is infiltrated, the breach the serosa into the peritoneum to the T4A, to that we need to know. And similarly for the colonic malignancy also, the extramural vascular investment is necessarily we need to identify, and retroperitoneal margin. So these three is well delineated by MRI than by the CT. We will be able to see the lesions there. What is the role of PET-CT? PET-CT, normally it is not a good thing for identifying the node or nodal status, but PET-CT is more important when you are suspecting there is the metastatic is there, especially when you are doing a CT and you are able to find out a nodule in the lung, then definitely to confirm that it is a malignancy, you may need to the PET-CT. But one of the most important thing in the PET and CT is a combination of the fusion scan. Whenever you have an obstructed lesion, when you have a colonic lesion which is been obstructed, where you will not be able to do the other investigative choice, the oral contrast cannot be given, or the other contrast is not going to be helpful. So those cases also the PET-CT is going to be of a very useful for that. For distal colonic malignancy, for distal colonic lesions with metastasis, PET, the CT is the workhorse where we do the contrast enhanced CT. But now when there is a liver involvement, when is if there is a MRI, as the two important principles which is being followed in MRI is, one is the diffusion weighted image and hepatospecific contrast agent. So these two are the added advantage given in the MRI, which is able to enable the well established secondaries in the liver. So diffuse weighted image and the hepatospecific agents we are going to use. Fusion scan, like what we talk about in the duplex scan with the Doppler and the ultrasonogram. Here the PET, the functional PET and the anatomic CT will be joined to the PET fusion scan. That will be useful. The last one, there is a lot of radio pharmaceutical agents, which are newer agents are coming on. One is called 68, the FAPA scan. That FAPA scan is going to be much useful for that, and this is very specific for the hepatospecific, the involvement of the secondaries in the hepatic. This is called positron emission tomography of a gallium-68 labeled fibroblast activation protein inhibitor scan. 68GA FAP diet. So this, the fibroblast activation protein, the scan, when this instead of only the FDG, and you are going to use the FAP, and that is the ideal choice for doing the MRI of the PETs for the secondaries in the liver we are going to see. Another concept is the tumor budding. Tumor budding. What is tumor budding? Tumor budding is the presence of single cancer cells or small cluster at the invasive margin of the tumor, and this is one of the most important predictor for whether this tumor is going for a metastasis. It need not be a T3 or T4 tumor. Even if it is a T1 tumor, where you are able to establish there is a tumor budding is there, and when you are able to establish the tumor budding, that you are going to see this tumor is going to metastasize, and that you need to take and all the necessary materials necessary for preventing that. Especially we use the term epithelial mesenchymal transition, EMT. This is one of the questions which will be asked for the in postgraduate. So this is an environment in which the tumor can able to migrate is decided by the EMT. That environment protection will be augmented if you are having a tumor budding. So the preoperative planning is going to tell us if there is a tumor budding, even in case of the T1 tumor, and that you need to take it as an aggressive tumor and go ahead with a higher margin. The extramural vascular invasion, and this is another important terminology which is used in the colorectal malignancy. What is meant by extramural vascular invasion? It is tumor cells found within the veins beyond the muscularis propria. When you are seeing that, if there is a beyond the muscularis propria, if the veins are infiltrated, we call it EMA positive. And the things which are called EMA, it is one of the independent prognostic factor to say whether this tumor is going to behave normally or aggressively. So if you can establish that the EMVA is positive in a MRI scan, and definitely you will be saying this is going to be the predict the tumor. So this, when will you say it is positive, when will you say it is negative? Not just if it is the tumor is infiltrating into the muscularis propria, we are not going to call it as a positive. Only when it is going to infiltrate into the veins, and if it is going to occupy the intermediate signal intensity within the vessel, the vicinity of the tumor is only going to call as a EMVA positive. So EMVA positive will be able to be seen. These are how this is been described. It is 0 to the 5th. If it is a 4th, definitely it is EMVA positive. So we need to take a measure. The next important thing is the circumferential radial margin. So what is this? It is a distance between the mesorectal fascia and the resected margin, the shortest distance. And within 1 millimeter, we say it is a negative. And if it is more than that, we are going to call it as a positive one. Both for the CRM for the colonic malignancy or MRF for the rectal malignancy, it is going to be important. For that, we must be always assured that the relationship of the peritoneum with the rectum. The rectum is not fully covered with the peritoneum. In the upper part, you have only a small tag of the peritoneum will be there. I will show you the picture. There is only the upper rectum is covered with there is only a small portion will be covered with the mesorectal fascia, but lower rectum there is no peritoneum. It is covered with the mesorectal fascia. So this again is important role to identify and whether the mesorectal fascia is involved. And based on that, even the tumor staging is going to be different. If you see the T4A MRF is negative because the peritoneum is breached, so that it is going to the T4A, but it will not be the mesorectum is not breached. So when both the mesorectum and the peritoneum is breached, it is going to be the T4A, but still it is MRF positive. So MRF positive, there we are cannot be able to do the complete mesorectal resection because the tumor has crossed the MRF. So that also it is going to be our investigations are going to tell us whether it is MRF positive. Another important terminology we should know is the anterior peritoneal reflection. So the point at which the peritoneum reflects from the rectum is called as an anterior peritoneal reflection. So that is the point from where the rectum will be getting devoid of the peritoneum, and only it is going to be covered with the mesorectum. So if you see the peritoneal cavity, the green one is a mesorectum, the peritoneum is shown as a blue, and that at particular point of the rectum, the peritoneum is getting reflected, and below that you are not going to have the peritoneum, only the mesorectum is going to be there. So that point of peritoneal reflection is the most important thing in identifying and the tumor, the behavior of the tumor. Like what we have the dentate line or the anal canal, when we have divide the upper anal canal, lower anal canal, and this peritoneal reflection going to make the rectum behave exactly in an opposite way or in a different way. The tumor above the peritoneal reflection, the tumor below the peritoneal reflection. So we need to identify in the scan that whether it is above or below, depending on what there is a seagull sign. All this will be the MRI findings which you are going to see. So with this, the intention to identify the extramural venous invasion and in the invasion to the mesorectal fascia, now it is mandatory, which the CT cannot tell us all these details, but the MRI is the only option when we are going to do in a proper way that these will be able to see. So the multiple studies has now demonstrated the investigation or the preoperative planning, MRI MRI is also indicated or mandatorily indicated for identifying the EMI and the mesorectal fascia reflection, especially when you are going to use the specialty agents that. It is highly accurate, highly reliable, and based on that, if there is a infiltration into the surrounding structure, the mesorectum is infiltrated or the mesocolic part is infiltrated, the patient can be put on the upfront surgery. So these are the areas where the important MRI finding is important for you to see whether you are going to have the patient on a only surgery or we are going to have the neoadjuvant therapy, especially when there is a CRM positive or it is threatened, it is mesorectal fascia invasion is there, then you get to do. If the T3B tumors with more than 5 mm spread to the perirectal fat, again it is a condition where that you need to give the adjuvant chemotherapy. If there is a sphincter complex is involved and the preoperative, the chemotherapy is indicated. If there is a extra mesorectal nodes, and again you need to give the preoperative chemotherapy. And T2, T3 disease with the bulky mesorectal nodes or adjacent organ invasion. So all these findings can be help us. So preoperative MRI scanning is going to tell us whether we are going to plan for the surgery alone or we are going to do the adjuvant therapy also. For that, definitely we need that very dedicated MRI or the high resolution MRI is needed. Also, it should be done with a phased array coil position, like what we now talk about the CA breast. You need to have the coil, and without doing a coil, doing a MRI for a breast is not going to be much useful. Similarly, you need to have a phased array coil which is inserted into the colon, into the anal canal and rectum, and if you take a CT, it will be good. It should be high resolution axial and it should be perpendicular rectal wall if you are taking, and if the coronal image you are going to take, it should be the parallel to the anal canal. These are the few techniques which is going to tell us that this MRI is going to be there. And what things we are going to see from MRI? Mainly first is the distance from the anal verge. Though may it looks simple, but identifying the anal verge and how far it is the distance from the anal verge is the most important thing to decide up to what anal resections you can do. So that is a point which will be telling us. Depending upon the distance from the anal edge, we have the three types of tumor: low rectal, middle rectal, and the upper rectal tumors. Depending upon the distance from which, if the low rectal tumor is if the tumor is arise within the 5 centimeter of the anal verge and it is account for the 1/3 of the tumor. Why it is important? If it is a low rectal tumor, whether we are going to do the anterior resection or low anterior resection, abdominal perineal resection, depends upon the peritoneal reflection, whether it is above the peritoneal reflection, below the peritoneal reflection, if the sphincter complex is involved or the not involved. So these three procedures you can do for the low rectal cancer tumor, but all that depends upon your MRI finding of the preoperative planning of how it is going to be done. The second thing which we will learn is a craniocaudal length, which is important for the lower limit and upper limit, which will be best. The third is a distance from the anolateral junction. The olden days we just put the finger. If you are able to see the finger, the tip is seen or felt by the finger, then we can't do the low rectal resection. That is what we said. But now the distance we can measure and we will be able to come to that. And how far the circumferentially, how far it is involved, whether it is involved only in one position or it is going to be involved in the entire position, and what are the tumor borders that can be assessed by the MRI, and what are the anterior peritoneal reflection, that already we have discussed about that, and relation to the tumor morphology, what kind of morphology of the tumor, that again depends upon the make your treatment, what kind of treatment you are going to do, whether it's a polypedal or it's a stalk attached, and the signal intensity. Suppose there is one concept called the content of the mucin. If your intensity is going to be high, and what kind of treatment you are going to give and the chemotherapy you are going to give will be there. So this is a final recommendation with two important organizations, the ACR and NCCN, but all that they say it is appropriate is CT or MRI with or without contrast, but NCCN says it is abdominal, which is with oral contrast they are recommending. But what they are not is not PET scan. NCCN do not recommend PET scan for a colonic cancer. But ACR says they do not talk that PET scan should not be done, it is not mentioned. Similarly for rectal cancer, the most important thing is the endorectal ultrasonogram is recommended. Again, it is for the age, so what is appropriate. If there is a liver second metastasis, MRI is most important, recommended. This deep for the each conditions they are going to do for that MRI. So again, identifying the nodes and what is the level of the nodes. The preoperative planning can tell us if it is the shortest diameter of the node. When it is more than 9 millimeter, that is considered as a positive node. So it is a malignant node. So the ultrasound or the MRI will be able to tell us whether you are dealing with a malignant node or not. So all this will be help us to make sure that we get to identify the loco-regional, the distant and the distant organ involvement and the extent of the tumor and the types of the tumor. That will be decided as help us to plan for our treatment. So preoperative imaging, it plays a major role in planning the treatment and giving an appropriate treatment to the patient so that we can give the better survival of the patient. So thank you for your patience here.
Thank you, Jayalal sir, for a wonderful elaborate enumeration of the investigating modalities in colorectal malignancies and how it can be useful in deciding management and prognosticating the disease. Thank you.
Thank you, sir, for beautifully highlighting how imaging not only supports diagnosis but plays a defining role in treatment planning and surgical decision making in colorectal cancer. Now I request Professor Dr. Gopinath sir to honor our speaker.
நாங்க பார்த்து அந்த 40 வருஷத்துக்கு முன்னாடி நான் பார்த்த மாதிரி அடிச்சுட்டே போகுது வெளியே அப்படியே தான். ஒரே நிமிஷம்
I request Professor Dr.Saravana Bhoopathi sir to honor our chairpersons. Now I request Professor Dr. Devanayagam sir, Professor Dr. Gopinath sir and Professor Dr. Irene ma'am to chair the next session. As we know, colorectal cancer is not just a surgical disease. Optimal care requires synchronized expertise of surgeons, medical oncologists, radiation oncologists, radiologists and pathologists, forming a tumor board, ensuring a evidence-based patient care decisions tailored to each individual clinical scenario. Here we welcome Professor Dr. Armugam sir, HOD of Medical Oncology, Tirunelveli Medical College, to give talk on MDT approach and guidelines in colorectal cancer, a tumor board approach.
Thank you. First of all, I thank our SG department for organizing this CME to commemorate our on the occasion of the superannuation of our beloved professor, Dr. Ramesh Bhoopathi sir. Thank you very much. So already 3 topics covered by our senior professors. So the extensively discussed the investigation modalities that is more important for going to the treatment approach. So I am going to talk on the multidisciplinary team approach and the guidelines in the colorectal management. So the management in the colonic cancer is almost straightforward. There is no confusion in the colonic cancer management. So I am going to cover on the rectal, mainly on the rectal cancer. So what is the tumor board or multidisciplinary team, which consists of oncologist, medical oncologist, surgical and radiation oncologist, and the supporting department like radiology and oncopathologist, and the now we are including the nuclear medicine department and the palliative care team and other department also a member of this multidisciplinary team. So why the MDT is needed in rectal cancer? So can we go upfront surgery or can we go with the neoadjuvant chemo RT or chemotherapy? So the decision can be taken with the everyone's knowledge. It can be discussed in the team. So that will improve the longer disease-free survival and overall survival with the preserved quality of life. We know the mainstay of treatment for the colon and rectal cancer is surgery, but we want to improve the DFS and overall survival. We need to add some other additional modality of treatment like radiation and chemotherapy. So in which rectal cancer we need this kind of approach? So very clear, T1 and T2 and 0 tumors we can go upfront surgery, but in T3 tumors and high or higher or the presence of nodal involvement. In this scenario we need which treatment go first, means neoadjuvant chemotherapy or chemo RT followed by surgery. That can be discussed in this team. So neoadjuvant modality is needed. Yes, upfront surgery will reduces the disease-free survival and overall survival. So various studies conducted. So the strong data of pattern of failure demonstrating a substantial incidence of local recurrence, regional recurrence and distant disease failure when surgery therapy is used upfront. So we have to treat either with chemo RT or chemo in rectal cancer in a locally advanced disease. So the MRI defined high risk factors already Jailal sir elaborated very well. So the local recurrence, if the patient has a threatened or involved CRM, there is increased chance of local recurrence, and extension into the intersphincteric plane for lower rectal tumors, there is increased chances of local recurrence. If the patient is having the extramural venous invasion, there is chances of distant recurrence, and the extramural spread of more than 5 millimeter or T4 disease has increased chances of distant recurrence. So in MRI is a main stay of investigation in rectal cancer. So the neoadjuvant RT, the role of neoadjuvant RT, this is a trial, is a preoperative RT in rectal carcinoma. So the preoperative RT followed by surgery and surgery alone. So that will see there is a double the chances of pelvic recurrence if we are going surgery alone. So surgery alone, so 25% of pelvic recurrence rate, and the overall survival is also if the surgery alone it is 39%. If you are combining with RT, so it is 46%. So neoadjuvant RT, the preoperative neoadjuvant RT followed by TME versus TME alone. This study is also shows the local recurrence is high when we are going with the TME alone. So even with all the stage except stage 1, there is no much difference in the 2-year local recurrence rate. Other stages like stage 2, 3 and even 4 in a metastatic with curative attempt. In that all these cases there is 2-year local recurrence rate is higher when treated with only surgery. So role of chemotherapy, surgery alone versus surgery followed by chemotherapy or surgery followed by adjuvant RT. So adjuvant chemo arm and radiation alone. So radiation alone will give only local control of disease, but in chemo arm that will give additional benefit of disease-free survival and overall survival. So many other additional evidences suggested that there is when we how to treat with all the kind of adjuvant treatment, the combination of the postoperative local therapy and also chemotherapy, that will improve the survival of the patient. So in this we should understand surgery alone has high local, regional and distant failure rates, and neoadjuvant radiotherapy improved local control. Chemotherapy works synergistically with RT and improves survival outcome, and chemotherapy alone has significant overall survival benefit. So in the multidisciplinary team, if a case presented, all the points can be discussed. So in the radiation, we can go discussion about the pre-op chemo RT or chemo alone or RT alone, or RT aspect you can go for long course RT or short course RT, and choice of concurrent chemotherapy can also be discussed. In surgery and versus non-operative management. This is a new entity, wait and watch, can be done in a rectal cancer, and chemotherapy, neoadjuvant versus adjuvant, and induction versus consolidation chemo and choice of chemotherapy can be discussed, and the biological response modifiers like EGFR inhibitor, VEGF inhibitor, multikinase inhibitor and immunotherapy. All these options can be discussed in the multidisciplinary team. The most used approach as of now, we are following neoadjuvant chemo RT for all the rectal cancers, especially in the mid and lower rectum, followed by surgery and followed by adjuvant chemotherapy. This is the practice as of now. The role of total neoadjuvant chemotherapy or total neoadjuvant therapy. This is a new entity. So this total neoadjuvant therapy means planned chemotherapy and planned radiation should be completed before surgery. So this will improve. The earlier the chemo, better the tolerance. So after surgery, the tolerability to the chemotherapy is little bit low. So before surgery, all the chemotherapy can be given. So earlier the chemo, better the tolerance for higher dose intensity, and the triplet regimen is easily acceptable, and earlier treatment that will improve the prevent micrometastasis and improve the long-term outcome. So response to the 5FU based chemo is better in non-metastatic upfront setting than the metastatic setting, and temporary ostomy closure may be done sooner without waiting for the completion of adjuvant chemotherapy. So this is another important point, and offers a favorable platform for the possibility of non-operative management and organ preservation. So there are landmark trials, the Prodige, OPRA and Prospect and Rapido. These are the trials supporting the total neoadjuvant therapy. So neoadjuvant chemotherapy with FOLFIRINOX and preoperative chemotherapy for patients with locally advanced rectal cancer is a phase 3 trial. So ITND means induction total neoadjuvant therapy. That is using modified FOLFIRINOX regimen once in 14 days, 12 weeks, followed by long course RT with capecitabine, and followed by total mesorectal excision, and followed by adjuvant FOLFOX into 3 months. So another arm is a long course RT with concurrent chemo RT, followed by total mesorectal excision and adjuvant FOLFOX and FOLFOX for 6 months. So primary endpoint is 3-year disease-free survival. So this shows in this trial they have included lower rectal tumors, T4 tumors, node positive tumors, lateral pelvic nodal positive tumors, and threatened or involved CRM and oligometastatic disease. So this shows absolute increase of 5-year survival. So the patient received neoadjuvant, total neoadjuvant therapy has increased pathological complete response of about 28% versus 12%. So absolute increase of 7-year survival, and DFS is 5.7%, overall survival 4.3%, and metastatic free survival 7.1%. and cancer specific survival is 3.8%. Then another trial is OPRA trial. It's organ preservation in patients with rectal adenocarcinoma treated with total neoadjuvant therapy. So the induction chemo with FOLFOX or CAPOX, followed by long course RT with chemotherapy, then with or without TME. So another arm, long course RT with chemotherapy, followed by consolidation TND, means consolidation chemotherapy with the FOLFOX or CAPOX, and with or without TME. here the primary endpoint is DFS and secondary endpoint is TME-free survival. There is no difference. There is no difference in disease-free survival, local relapse-free survival and distant disease-free survival. So here the induction total neoadjuvant therapy is equivalent to consolidation total neoadjuvant therapy if it is FOLFOX. So the take-home message is, if you are giving a total neoadjuvant therapy, the ideal chemo backbone is FOLFIRINOX. So other similar phase 2 trial also shows that there is no much difference with the induction total neoadjuvant and consolidation total neoadjuvant. So for better response, the Prodige 23 is the way to go, and induction has to be with a triplet protocol, and response to triplet can predict a good response to further therapies. So induction chemotherapy before RT has a better treatment completion rate and successful long-term outcome. So at a higher incidence of myelosuppression of grade 3, so induction chemotherapy patients to be chosen with a good performance state and high risk tumors. So the another trial is a prospect trial. Here they are using modified FOLFOX6, and here the aim of this trial is, can we omit RT? So this induction chemo with modified FOLFOX, if the size of the reduction is less than 20%, then proceed with RT, then go for surgery. If the size reduction is more than 20%, there is no need for RT, go for surgery, and after surgery you have to assess the pathological specimen. If achieve pathological complete response, there is no need for RT. If there is a less than PCR, then go for long course RT. So in this study they have included only patients with T3 disease and 50% node negative and 85% mid and upper rectal tumors, low risk tumors, and those who are not eligible for the radiation. So we can avoid radiation in this setting. Mostly the patients are elderly patients and frail patients. So we can avoid RT. So the Rapido trial, so this is a short course radiotherapy followed by chemotherapy before TME versus preoperative chemo RT, TME and optional adjuvant chemotherapy for the locally advanced rectal cancer. So planned schema is short course RT followed by CAPOX6 or FOLFOX into 9, then followed by TME. Another arm is long course RT followed by TME and followed by adjuvant chemo. So here the patients are T4, N2 and extramural vessel invasion and the MRF positive. So here the better disease related treatment failure, better metastasis free survival and increased local regional recurrence. So the take home message is Rapido by design did not mandate adjuvant chemotherapy in a long course RT arm, thus biased by design and losing its validity. So another is the OPRA trial. This OPRA trial we should learn, the points to learn from the OPRA trial is all tumor regrowth we can in wait and watch patients occurs during first 2 years, and regrowth after 3 years is extremely rare, and half of the patients with rectal cancer treated with total neoadjuvant therapy preserved their rectum after 5 years of follow-up. So the rates of organ preservation is higher than the rate of pathological complete response in patients treated with total neoadjuvant therapy and TME. So probably due to offering wait and watch for the near complete response patients also. So the chemotherapy resulted in a higher organ preservation at 5 years compared to the RT, and DFS does not differ significantly between the who undergo immediate TME after TND versus salvage TME after regrowth. So there is no difference in the DFS. So the statement on the neoadjuvant options, chemo, RT and surgery all play a significant role in the management of rectal cancer. Long course chemo RT followed by surgery, and adjuvant chemotherapy remains the most commonly used modality in the locally advanced rectal cancer, while recommendations prefer total neoadjuvant therapy. The high risk tumors in fit patients unequivocally benefit from triplet induction chemo followed by long course RT and followed by surgery and adjuvant FOLFOX or CAPOX. So good risk tumors in frail patients can be managed with the prospective way and can avoid RT. And for those not willing or unfit for surgery, ostomy can be managed with wait and watch approach if CCR is attained and with higher suspicious of NCR patients, that is near complete response patients. So addition of oxaliplatin to RT. So usually we will give concurrent chemo RT along with the capecitabine or 5FU. There is no, oxaliplatin is no use. So no improved response rate and it has a higher toxicities. And utility of the biologies are multikinase inhibitor in the neoadjuvant setting. So cetuximab, panitumumab, bevacizumab, ramucirumab and multikinase inhibitors have no role in neoadjuvant or adjuvant setting as a single agent in combination with chemotherapy or with RT, but there is a role in the immunotherapy. So in DMMR or MSI high tumors, we have to use the immunotherapy. So DMMR and MSI high tumors already discussed by Dr. Alex sir. So mismatch repair system acts as a DNA spell checker fixing errors made during cell division. So MMR system has 4 genes, MLH1, MSH2, MSH6 and PMS2. So when one or more of these proteins are absent or non-functional, it prevents the correction of DNA mismatch. So the breakdown of this mismatch repair system can be sporadic or Lynch associated. So numerous mutations inside the DMMR cancer cells leads to production of abnormal protein known as neoantigen. So neoantigen acts as a flag for our immune system to recognize and cause selective cell killing. So immune checkpoint inhibitors by releasing the intrinsic immunological breaks acts excellently in the DMMR tumors. So we have to check for upfront all the colon and rectal cancer, you have to check for this MMR and MSI. So approved agents are dostarlimab, nivolumab and pembrolizumab. If the complete response after neoadjuvant IO means immunotherapy, surveillance can be done. If less than CR, can be proceeded with again RT, surgery and adjuvant chemotherapy. So other biomarkers in the neoadjuvant IO approval are POL-E and POL-D ultra mutated tumors. So how to manage an oligometastatic disease? So what is mean by oligometastasis? The traditional clinical definition of oligometastasis is 1 to 5 metastatic lesion, occasionally more if complete eradication is possible, up to 2 metastatic sites, controlled primary tumor optionally resected, and all metastatic sites must be safely treated by local therapy. So the disease related factors include size of the tumor, site of the tumor, status of the primary tumor, previous treatment free interval and previous treatment and their respective outcome. Is it a synchronous metastasis or metachronous metastasis? So all these factors came into account for managing these patients. By ESMO guidelines, the liver metastatic in colorectal cancer. So MDT has an ongoing role throughout the metastatic colorectal cancer patient pathway to review the diagnostic workup to define whether or not a patient has clearly resectable or unresectable metastatic disease to consider management of the primary tumor. So patient defined as initially unresectable could have a second reassessment of resectability and preferably within 2 to 3 months of starting therapy as proposed by the expert consensus. So liver metastatic, we have to assess it is a potentially resectable or initially unresectable or never resectable. So potentially resectable, you can go upfront surgery or post neoadjuvant chemotherapy or RT, you can assess, and initially unresectable tumor, you can go with neoadjuvant chemo RT, and if DMMR, then go consider immunotherapy. Then you can do second assessment of resectability at 2 to 3 months interval. So never resectable, you can go for chemotherapy. So 5-year survival rate of potentially resectable liver metastasis when curative treatment is given, the 20 to 45%, there is a 5-year survival rate. So the criteria for R0 resectability in colorectal liver metastasis depends on the technical and oncological criteria. The technical criteria are resectability is not limited by number, size or bilobar metastatic involvement. If tumor may be resected and we should have a remnant liver of 30%. Other RT may be added to surgery to achieve a complete treatment or provide an alternative to resection if inoperable due to frailty or poor anatomic effective. Prognostic factor that impact the disease-free survival or likelihood of cure. Onset of metastasis. Is it a synchronous or metachronous? Clinically aggressiveness of the tumor and concomitant extrahepatic disease. So the liver metastatic, how to approach? So the good technically feasible and favorable oncological outcome. If both are there, then upfront surgery followed by adjuvant therapy. Our goal is R0 resection. If it is unresectable or unfavorable prognostic criteria, go with neoadjuvant chemotherapy and reassess after 2 months of therapy. Then you can go for surgery. So median survival rate after resection are 2 to 3-fold higher in patients treated with systemic therapy alone. So even in unresponsive tumors, we can go for surgery. So patient unresponsive to first-line chemotherapy should not be denied resection or ablation of metastasis, since the outcome of resected patients after second-line treatment could be a favorable one. So the timing of resection, if the patient received chemotherapy alone, we have to wait for at least 4 weeks with the last administration, and chemotherapy with anti-EGFR, we can wait for 4 weeks since the last dose, and patient received bevacizumab, we have to wait for 6 to 8 weeks. So as soon as the metastases are technically resectable, unnecessarily prolonged administration of chemotherapy increases the liver toxicity and higher post-operative morbidity. So in this, if other sites of metastasis like lung mets or peritoneal metastasis, in a lung metastasis 5-year survival rate of 25 to 35% if it is resected. And the limited peritoneal metastasis, complete cytoreductive surgery followed by HIPEC offer better survival. And another newer treatment on active research is PIPAP, that is pressurized intraperitoneal aerosol chemotherapy. So ovariectomy, lymphadenectomy and resection of selected other single metastases have also shown survival benefit in the patient series. So to sum up, the rectal adenocarcinoma, so MMR microsatellite stability status, a must before proceeding all metastatic, all colorectal cancer. If T1, T2 tumor, N0 tumor, upfront surgery. So pathological T1, T2, N0, if there is a proficient MMR surveillance, T1 to T4, N0, deficient MMR is also surveillance. Pathological T3 and node positive, go for adjuvant RT and chemo. T3 and above, N plus tumors, go proficient MMR, go for performance status is good, triplet induction followed by RT. If it is deficient MMR and the triplet ineligible and deficient MMR, you can go for neoadjuvant IO, immunotherapy. In the colonic adenocarcinoma, resectable tumor, upfront surgery, you have to check for the PMMR, the proficient pathological stage T1, T2, N0, observation, T3, N0, up to T3, N0, you can go for observation, and T3, N0 with high risk features, you can go with the capox 3 months. And N1, N positive, node positive disease, low risk and high risk tumors, go for capox regimen into 3 months, and high risk tumors 6 months. So non-resectable, clinically T4B, bulky nodal disease, oligometastatic, go for neoadjuvant chemotherapy and downsize the tumor and go for surgery. Thank you.
Long question routine. Yes, thank you. It's a nice presentations. Elaborate all details including the radiation and the chemotherapy, including all. It's a good presentation. Any questions, please?
It's a small doubt, Dr. Armugam. It's a totally neoadjuvant is evolving, as you said earlier. We are worried about we are interested to know about the total neoadjuvant, particularly the sphincters are involved. Whether the study is showing any difference between the upper mid rectum, between the lower rectum in total neoadjuvant radiotherapy, whether it is better in upper and mid rectum or results are bad in lower rectal cancers, or is there any difference or there is no difference?
sphincter saving surgery and the rectal involvement, upper rectal involvement, directly we can go for surgery, sir. Upper rectum or rectosigmoid is go for surgery. Mid and lower rectum we can go with neoadjuvant chemo RT and followed by surgery. For total neoadjuvant chemotherapy, organ preservation will be high. So organ preservation in the sense sphincter preservation, or we can option for the wait and watch in the total neoadjuvant therapy. The major issue with the total neoadjuvant therapy is chemo-related complications management only. Doses are high because of 4 drugs we are using.
Thank you, sir. Your talk beautifully highlights the evidence-based protocols which can transform the outcomes of patients with colorectal cancer. Now I request Professor Dr. Gopinath sir to honor our speaker. I request Professor Dr. Saravana Bhoopathy sir to honor our chairpersons. For next session, I request Professor Dr. Karthikeyan sir, Professor Dr. Saravana Bhoopathy sir and Dr. Sachin Karthik to chair the session. With rising global burden of colorectal malignancies, surgical techniques have evolved not just in complexity but in precision and functional preservation of oncological safety. This session promises to provide deeper understanding of how modern surgical approach, enhanced technology aid in colorectal cancer care, from minimally invasive techniques to organ preservation. We are truly honored to have with us Professor Dr. Padmanabhan sir, retired head of the department and Professor Department of Surgical Gastroenterology, Madurai Medical College, to talk on evolving surgical strategies and oncosurgical principles in colorectal cancer management.
Good morning to all of you. At the outset, I would like to thank Professor Prabhakaran for inviting me to attend this very important function, because myself and Professor Saravana Bhoopathy, we are associated for more than 2.5 decades. We both of us have been in Madurai. I was initially working as assistant professor, then I became professor long back. I had been professor at HOD for more than 17 years. So thank you so much. Since the time allotted is only 10 minutes or 5 minutes, I prepared a slide very precisely. The topic is the evolving surgical strategies and oncosurgical principles in colorectal cancer management. The colorectal cancer, there has been a rise in the incidence globally and rise in the mortality rate overall. And there has been changing demographics and risk factors. The risk factors are now, the incidence is higher with modifiable, the cancers associated with modifiable risk factors and associated with higher incidence of elderly population, to whom it is very common. Recently, there has been shift towards the early detection and organ preservation. Going to the oncosurgical principles of colorectal cancers, So we aim to achieve RGO resection, that is complete clearance. For benefit of postgraduates, I used to repeatedly tell the definition of radical surgery. Radical surgery is defined as monoblock or en-block excision of the tumor-bearing area or organ and regional lymph nodes, along with intervening fibrofatty tissue, lymphatics, lymph nodes, and blood vessels. So this is a definition of any radical surgery. So our aim is to have RGO resection. We should achieve adequate lymphadenectomy for colon and rectal cancers. The minimum number of nodes for adequate staging is 12 nodes. And we should give respect for the embryological planes. This is the most important in achieving the RGO resection. For colon, the recent concept is complete mesocolic excision, and for rectal cancer, it's a TME. And the more importantly, we should try to preserve the function as far as possible. That is preservation of the anal sphincters. This is achieved only by multidisciplinary approach, as described in detail by my previous speaker, the medical oncologist. This is the definition of R0, R1 and R2 resection. R0 is there should be complete gross as well as microscopically negative status. Going to the RGO resection for colonic cancers, the margin to be given on the bowel side is at least 5 centimeters on both sides. The line of transection depends on the artery to be ligated at the origin. So the entire area of bowel supplied by the artery should be removed. The aim is to clear the cancer cells in the lymphatics and lymph nodes, because this abdominal viscera is a deep organ. So deeper lymphatics, they accompany arteries, whereas superficial lymphatics accompany veins. So we should remove the cancer cells in the lymphatics and the lymph nodes. So for that, we should ligate the vessel supplying that area bearing the tumor, so that we can clear the lymphatics as well as lymph nodes. So for colonic cancers, this is achieved better with CME with CVL. CVL means central vascular ligation. This is a schematic diagram showing type of colectomies. This depends on the vessel that you ligate to clear the lymphatics and lymph nodes. The concept of complete mesocolic excision and central vascular ligation was followed by the TME concept, total mesorectal excision concept, developed by R.J. Heald for rectal cancers. Here, if you do comparing the conventional colonic surgeries with CME with CVL, you achieve more distance from the tumor area to the high vascular type, and the length of bowel removed is also higher, and area of mesentery is also higher. Here, you don't breach the embryological planes. We remove the bowel and mesentery with the enveloped fascia in toto, without breaching any plane. So this is associated with increase in the survival rate along with low recurrence rate. The 5-year survival rate overall with CME and CVL for colonic cancer is more than 89%. In the diagram, you can see the plane of, this on the left side, you see the conventional plane of dissection. On the right side, this is a proper plane of dissection posteriorly, where the Toll's fascia is lifted up. So you don't violate the embryological plane. So going to the surgery for rectal cancers, so these are all various surgeries described: anti-resection, APR, pelvic excenteration, and local excision. So anti-resection is defined as high, low, or extra low, depending on the site of anastomosis. High and low anti-resections are done for sigmoid growth and upper rectal tumors where the anastomosis is colorectal. Whereas ultra-low dissection is coloanal anastomosis. The anastomosis sited below the peritoneal reflection, that is to the anal canal, below the lever training. The AP abdominoperineal excision is a sphincter ablating surgery. It is classified into intersphincteric, extralevator and ischioanal. I will show in the diagram. And the pelvic centration is a more radical surgery. The types for rectal cancers are posterior and total pelvic centration. Anterior is not indicated in this case. There are many local excision methods available. We have got transanal excision by Parks and Journeys, transanal endoscopic microsurgery and transanal minimal invasive surgery. Here in rectal cancers, the margin of bowel to be given is generally 5 centimeters proximally, but the proximal line of transection depends on the artery to be ligated at the origin, similar to the colonic cancers. The minimal distal margin to be given as per the guidelines, the NCCN and the other standard guidelines are 2 centimeters distal. In selected cases, very close shave operation described by Kusheri, Alfred Kusheri, that is 1 centimeter or sometimes low, can be used in selected cases. This should be selected in very small tumors, preferably T1 tumors without any high risk criteria. High risk means without any perineural invasion, lymphovascular invasion, without any poor differentiation and lymphnodal metastasis. So this is achieved better with TME. TME is nothing but total mesorectal excision. Mesorectum is nothing but the 2 layers of peritoneum covering the fiber fatty tissue, lymphatics and lymph nodes and blood vessels, which lies posterior to the rectum. The important point is that the mesorectum does not extend up to the levator trani. There is 1 or 2 centimeters the mesorectum free area in the rectum. So this is the TME was developed by R.J. Heald from UK or from the England, the Basingstoke Hospital. So actually this R.J. Heald was working in a very small tall headquarters hospital in Basingstoke. He himself analyzed the results of the conventional rectal surgery by blunt dissection and other methods. So having seen many recurrent cases, he developed his own technique of using sharp dissection with scissors. So he cleared the entire mesorectum and he could demonstrate very good results with least recurrence rate and overall improvement in the survival rate. The types of TME are partial or total. The concept of partial or total depends on the distance where the bowel should be transected. From the macroscopic margin, at least 2 centimeters as described previously, the bowel should be 2 centimeter distance should be given clearance, whereas the mesorectum, 5 centimeter of the mesorectum should be there from the lowermost part of the tumor. So because the tumor can spread to the mesorectum to the lymph nodes or can give rise to deposits in the mesorectum up to 5 centimeters from the lowermost margin. So for upper rectal tumors, naturally it is enough if you do partial mesorectal excision. The red line indicates the remaining mesorectum in the lowermost part, whereas lower rectal cancers warrants complete mesorectal excision. Going to the types of anterior section, I already told you high and low. In high anterior section, the anastomosis is colorectal and the anastomosis above the peritoneal reflection. Whereas in low anterior section, it is also colorectal, but the site of anastomosis is below the peritoneal tree. The importance of whether it is high or low lies in the fact that peritoneum can absorb additional 900 ml of fluid per day if there is a secretion. So normally it can absorb additional 900 ml of fluid per day. If the secretion is more than 900 ml, or if the absorptive capacity is decreased because of inflammation, peritonitis, the absorptive capacity comes down. So here in high anterior section, since it is above peritoneal deflection, even if there is a collection because of manipulation, bleeding or something else, the fluid will be absorbed. Whereas in low anterior section, since it lies below the peritoneal deflection, if there is a centimeters, or if there is involvement of anal sphincter, external sphincter involvement or levator involvements, or the failure of neoadjuvant therapy, the patient has got poor anal incontinence. Even if the tumor lies higher, the patient has incontinence, there is no meaning in conserving the sphincter and doing anastomosis, because patient will have features of perineal colostomy. Even if you do anastomosis in little bit higher up, if the patient has got incontinence, patient will have perineal colostomy features. Or with the CRM is positive, and recurrent and residual disease, and sometimes patient may prefer sphincter ablating surgery because he may feel that managing the permanent stoma in the abdomen is easier than managing the the low-lying stoma with, low-lying anastomosis with more frequent passage of stools. This is a schematic diagram showing the types of APR, intersphincteric, extralevator and ischial region. What should be done? See, for the intersphincteric type of APR, should be restricted only to very early cancers, T1 cancers, or very early T2 without high risk features. It should be restricted only to the infiltration only to the internal sphincter. What should be done routinely is the extralevator type of abdominal perineal excision, where levator should be removed along with the external sphincter. The ischial type of APR is indicated if the tumor extends into the ischiorectal fossa and presents a bulky disease, whereas where you should remove the entire ischiorectal fossa along with levator and everything, external sphincter muscle complex. Naturally, this requires plastic reconstruction, or else the small bowel will come into the peritoneum. So it requires major plastic reconstruction. So pelvic excenteration, as I told, is a very major ablating surgery. It should be done only with the intent of curative surgery, not as a palliation. It is indicated in locally advanced rectal cancer, recurrent rectal cancer, and if there is involvement of more than one compartment. Going to the evolution of surgical techniques, now this is an era of minimally invasive procedure. There has been a change from open to laparoscopy, then laparoscopy to robot, and now it's a transanal total mesorectal excision, other transanal procedures. Minimally invasive procedures, they are associated with very good recovery. Recently, AI guided, artificial intelligence guided and personalized interventions are emerging. The other nose, nodes and the internal surgeries, they are in early stage for treatment of rectal cancers. I think minimally invasive surgery and robotic surgeries are going to be covered by subsequent speakers, so I am not going to recover. This transanal TME is a new innovative treatment method for low rectal cancers. There is improved visualization with TATME and access. It requires experience and facilities, and patients should be carefully selected for these procedures. Going to the organ preservation, as my previous speaker described, there is a role for wait and watch for those with complete response. This means you give neoadjuvant chemo-RT, do the assessment with clinical and radiological, and if the PET-CT shows no evidence of residual tumor, with showing no evidence of tumor with SUV max in the range of benign disease, then there is a role for wait and watch. Is it advisable to follow wait and watch for all the patients with complete clinical response? No, because the data shows that 30% of patients with complete radiologic response, they harbor malignant cells. So we are justified in doing radical with the intended proposed definitive surgery as we plan. So in 30% there is a residual tumor cells. And the local excision, as I described, there are so many procedures like transanal, Park's transanal excision, Journey's excision, TEM and TAMIS should be selected in selective patients. The local excision procedures require intensive follow-up protocols. Like all the colorectal cancers, they require multidisciplinary approach. The neoadjuvant chemoradiation has become the standard for rectal cancers. For all rectal cancers, resectable rectal cancers, we submit the patients for neoadjuvant chemo-RT. And there is a choice between the short-term and long-term, and I think short-term radiotherapy has become obsolete now. Only long-term chemo radiation is used with 28 fractions, totally 50.4 gray. Is there any role for total neoadjuvant therapy? So there is a trial showing benefits which shows very good improvement in the complete pathological response. So the thing is, the sequencing is important, which to be given, whether it's radiotherapy, chemotherapy, surgery, and post-operative adjuvant therapy. So the sequencing is important. There are many trials comparing the upfront surgery followed by adjuvant therapy in the post-op, and the neoadjuvant therapy either as partial or the total neoadjuvant therapy. And there are many trials showing improvement with the neoadjuvant therapy. This ERAS is there for all diseases. This is the most important slide. What is the role of molecular and personalized therapy for colorectal cancers? Whenever you see a colorectal cancer, you do colonoscopy and take biopsy, send the specimen for histopathological examination, and send the blood sample for MSI status and MMR. MSI is microsatellite instability, MMR is mismatch repair gene status. So what is the role of MSI and in guiding the immunotherapy? And second, another thing is, the next slide, this is an important slide for MCH postgraduates. Why do you want to do MSI and MMR? Because patient with MSI high and deficient MMR, they will have very good prognosis. They respond well to the immunotherapy. The immunotherapy is nothing but immune check inhibitors, like the approved drug is pembrolizumab, and there will be poor response to the commonly used drug, this 5-fluorouracil. This is most important. So this test is done with the blood sample. 2.5 ml of blood is enough to do the test. You can get the result in 3 days. They charge, I think, 2,000 rupees only. So before, so in the OP itself, we can, when you take the colonoscopy and biopsy, simultaneously you do the MSI and MMR genetic testing. Because you can assess the prognosis, you can find out whether the patient is going to respond to immunotherapy, and the response to 5FU can be predicted. And what is the CT means? Circulating tumor DNA shaping adjuvant therapy. What is that? Nowadays, we are in the era of testing to find out whether the tumor cells are circulating in the blood. So you can find out circulating tumor cells and circulating DNA in the peripheral blood. You may see complete response, both clinically, colonoscopically, and even PET scan wise, there will not be any evidence of malignancy. But if you find the circulating tumor cells or circulating tumor DNA, that means patient has residual disease. So you should submit those patients for the appropriate therapy. And in the future, you are going to see very sooner the intraoperative guidance with artificial intelligence. So, to conclude, our surgical goal is to achieve RGO resection of the sites with the preservation of function, that is preserving the sphincter as far as possible. This is possible with neoadjuvant therapies, and there has been a shift towards tailored, minimally invasive treatments compared to radical open surgeries, and multimodal therapy, including the molecular strategies, and would shape the future of the treatment of colorectal cancer in the future. Thank you so much. I think I completed in time, no?
Yes, sir. Excellent lecture on perspective, surgical perspective, sir. Very useful for the postgraduates. Any questions from the audience?
Your competent insights truly deepened our understanding of how surgical innovation is aligning with oncological principles to offer best possible outcomes in colorectal cancer surgery. Thank you, sir. Now I request Professor Dr. Jayalal, sir. Now I request Professor Dr. Jayalal to honor our speaker. Now I request Professor Dr.Prabhakaran sir to honor our chairpersons. Now there is a change in topic. We now shift our focus on advanced laparoscopic techniques in colorectal surgery, a domain where precision planning and fineness come together in operating room. Professor Dr. Baiju Senadipan, HOD, GA HPB Institute, Senadipan Institute of Medical Sciences, Trivandrum, is here through online mode to present on advanced laparoscopic techniques in colorectal surgery, expert insights. I request Professor Dr. Padmanabhan sir, Professor Dr. Deswant sir, and Professor Dr. U.P. Srinivasan sir to chair this session.
Can you share?
Yes, sir. We cannot clear it clearly. So, good morning, sir. This is Dr. Jaswant. Baiju, sir.
Sir, okay, sir. Please give me address, sir. Offline, sir.
Due to technical issue, we are moving on to next session. We request Dr. Balam. Sir, listen. Creating a stoma is never a decision taken lightly, one that significantly impacts patient outcomes and quality of life. It involves a careful balance of disease severity, surgical risk, patient comorbidities, and anticipated recovery. To expertly guide us through this, we have with us Professor Dr. Rakesh Fernando, Head of the Department of General Surgery, Thuthukudi Medical College, for a talk on evidence-based indications for temporary and permanent stomas, optimal timing for diversion and reversal.
Good afternoon all. At the outset, let me thank Professor Prabhakaran for having made me a part of this update on colorectal surgeries. And I, along with the Department of General Surgery, Thoothukudi Medical College, convey our heartfelt wishes on the retirement of Professor Saravana Bhoopathi, sir. Wishing you a long, illustrious post-retirement life, sir. So, let me, with due respects to all my senior professors, many of whom are my teachers, including Jashwant sir, I like to start my talk with a small case snippet for the benefit of the postgraduates, and this talk will be for the postgraduates alone. A 55 years old male, a case of proven midrectal adenocarcinoma, posted for surgery tomorrow, presents with the perforative peritonitis on the previous day. What would you do? So there are various options which will be available for you. You can either do a LAR without a stoma, you can do it with a protected stoma, or you can do a defunctioning stoma alone, depending on the level of contamination, or you can do a Hartmann's procedure with an end stoma. So we have various options lying before us. So how can stoma benefit a patient in such a situation? So the next 10 minutes of my talk will be about stoma, the indications for performing a stoma, the appropriate timing for doing it and undoing it, and a few updates and journal references to augment my discussion on this topic. So, stomas, also known as ostomies, or a form of means of fecal diversion, it is done to protect a distal bowel, either as to protect it while doing anastomosis or to defunction it for a while. And this is usually achieved by exercising a part of the bowel, either the small bowel or large bowel, and it's predominantly done for GI indications. It can be either benign or malignant. It's also done for genitourinary indications and also for neurogenic bowel dysfunction. But I will restrict myself to stoma creation and its utility in GI malignancies, especially for colorectal malignancies. So this exercisation of bowel can be temporary if there is a feasibility of re-establishing the bowel continuity at a later date, or it can be permanent if a distal bowel is not viable or it's absent, or you remove it for some purpose. And as I said, it can be either the small bowel which is brought out when it's known as ileostomy, or and the large bowel is brought out, it's known as a colostomy. And again, it can be either the bowel can be brought out in continuity when it's known as a loop ostomy, or in cases of a permanent colostomy, it's usually an end colostomy. So coming to the indications for stoma creation, the temporary indications will be to protect low pelvic anastomosis, to prevent a leak rate, especially in cases of low anterior resection for rectal cancers. For that matter, literature recommends that all anastomosis, which is below the peritoneal reflection, or around 5 to 6 centimeters from the anal verge, will benefit from diversion protectors stomas. It can also be done in cases of anastomosis and colorectal malignancies above the peritoneal reflection in case of high-risk anastomosis, like if the bowel is distended with a poor vascularity and the suture line is under tension, or there is a little amount of sepsis due to a perforation. In such cases, you can go for you can temporarily divert the fecal stream by performing a stoma. It's a temporary indication for a stoma, temporary stoma. Or in cases where you suspect an obstruction, an impending obstruction, in cases where you are subjected to neoadjuvant chemo-RT, the patient is getting prepared for a surgery. In such cases, you can do a diversion as a temporary means to prevent an obstruction. Or in cases which present to you with an obstruction or a perforation, you can do a temporary diversion to stabilize the patient before you can take them up for a definitive resection. Sometimes you may have to do it as a palliative bypass in unresectable tumors when the patient presents in a very advanced state and you find that the tumor is unresectable. And finally, you can do a temporary stoma again in cases where you have taken up a case for a colorectal surgery and you haven't done a stoma at the primary instance, but then unfortunately the patient develops a leak, and as a salvage procedure, you may have to go in and do a temporary stoma to decrease the leak severity and to promote the healing process. Indications for creating a permanent stomas in colorectal malignancies will be When you remove the sphincter complex as you do in APR, or if the disease process involves the pelvic floor and you need to do a wide excision when it's involving the sphincter or the levator ani muscles. Sometimes if you do a resection and you find that the distal margin is oncologically unsafe for anastomosis, the patient may end up with an colostomy. And in instances where you have done an anastomosis and then the patient develops a leak and you find that it's redoing an anastomosis will not be possible, the patient may end up in a permanent end stoma. And you can also do it in patients with, you have done a temporary ostomy, assuming that the patient will be taken up for a redo anastomosis, but then you find that the comorbidities or the poor nutritional status prevents the patient from undergoing a repeat surgery, and the temporary stoma becomes a permanent stoma. Sometimes you may have to do a stoma alone in cases of unresectable distal rectal cancers to prevent, in order to avoid an obstruction or for a palliative symptom relief of pain. Stoma creation can be done preoperatively. Predominant of the cases of colorectal malignancies, you do a preoperative planning and you fashion the stoma accordingly. Sometimes intraoperatively you also decide to do a stoma depending on the perfusion status of the bowel or the level of contamination in the abdomen, or if the anastomotic tension lines or under suture lines are under tension. So undoing a stoma, standard practice is, standard reversal is after 8 to 12 weeks, that is 2 to 3 months after creation of a stoma. So this depends on the clinical and imaging status, then the patient is taken up a stoma. But literature supports early reversal within a period of 10 to 14 days if there is no anastomotic leak or no chemo is planned. And I heard in this talk by Professor Armum that in case of total neoadjuvant chemo, even if the chemo is planned, the patient can be taken down, the stoma can be taken down. And in cases where the patient is supposed to undergo chemotherapy, ongoing chemotherapy, and if there is a little amount of sepsis or the anastomotic healing is not adequate, then the patient can be taken down for a delayed reversal, which is after 6 months. So now we'll come to certain updates. So this topic was supposed to be evidence-based. So now, is a protective diversion needed or not? So journal references, various journal references. This one in the International Journal of Colorectal Disease says that a protective diversion after a colorectal malignancy surgery prevents anastomotic leak and reduces the morbidity of for the patients. This one in case of surgery says that, is colostomy necessary for all patients, ileostomy or a diversion necessary for all patients. This limits diversion to certain group of patients. It says that patients who are having anastomosis below the peritoneal reflection, patients who have an anastomosis within 6 to 7 centimeters from the anal verge, a male pelvis with a narrow pelvis, or immunocompromised patients, or selectively candidates for a diversion ostomy. Rest of the candidates can have a primary anastomosis. And this journal, a large multi-center trial, randomized trial, prospective trial by Matheson et al. This one is a landmark publication which has said that this protective diversion prevents morbidity and prevents anastomotic leak for patients undergoing colorectal malignancies. It quantifies this anastomotic leak and says that there is a reduction of anastomotic leaks from around 28% to less than 10% in patients who have a protective diversion in case of anastomosis and for a colorectal malignancies. So, the evidence-based consensus says that diversion has an advantage over primary anastomosis without a diversion. Reduced anastomotic leak rates and reduced reoperation rates. However, stoma-related morbidity and the added risk of a reversal surgery is always there for the patient. Again, there is a controversy whether you do an ileostomy or a colostomy. So, this World Journal of Surgery says that ileostomy has an advantage over colostomy. It says that ileostomy has less stoma-related complications and the post-operative, post-reversal incision hernia rates are less with ileostomy when compared to colostomy. However, this journal, a British Journal of Surgery, says that colostomy is better than ileostomy because the management of the stoma is much better for the patients and the fluid and electrolyte loss is much less compared to ileostomy. However, this meta-analysis proves beyond doubt that ileostomy is always superior to colostomy as far as the stoma-related complications and postoperative management is concerned. However, this also adds to the point that patients who are having a renal impairment will benefit from a colostomy rather than a ileostomy since they have to do a lot of fluid and electrolyte management. So what is the evidence-based consensus again? It's ileostomy, and when it's a short term, when you plan that the takedown can be for a short term, you can plan for ileostomy, or if you're planning for a delayed reversal, colostomy may be of benefit for the patient. And except again to emphasize, for renally impaired patients, a colostomy will be better than an ileostomy, and for rest of the patients, ileostomy scores over colostomy in colorectal malignancies. Coming to reversal, which would you prefer, early reversal or a delayed one? This journal says that early reversal, which is within the 10 to 14 days of post-colorectal malignancy surgery, in uncomplicated cases, has an advantage in the form of morbidity and quality of life for the patients and is to be practiced. And this is re-emphasized by another recent publication in the colorectal disease, April 2025, which again emphasizes that ileostomy is much better than colostomy, and early closure of the stoma within 10 to 14 days is much better than a standard or a delayed closure, and it adds to the quality of life of the patient. So the evidence-based consensus is that early reversal of the stoma is of benefit for the patients. So, my dear postgraduates, a few take-down points. No stoma is universally better. It all depends on the comorbidities which the patient has, the primary status of the disease, the anatomical location of the disease. But remember, this evidence-based consensus is that protective diversion always scores over non-diversion in case of colorectal malignancies. Ileostomy scores over colostomy in cases of diversion, and early reversal has an advantage over a delayed reversal. Thank you.
Thank you very much, sir. Your talk truly highlighted critical nuances in decision making around stoma creation, either temporary or permanent, and timing of diversion reversal. Now I request Professor Dr. Jeswan sir to honor our speaker.
Chairpersons to continue the next session.
I request our chairpersons to continue the next session. Our next session is on advanced laparoscopic techniques in colorectal surgery, a domain where precision, planning and fineness come together in an operating room. Professor Dr. Baiju Senadipan, HOD Senadipan Institute of Medical Science, Trivandrum, is here through online mode to present on advanced laparoscopic techniques in colorectal surgery, expert insights.
So good afternoon. Am I audible?
You are audible, sir. I am Dr. Jeswan speaking. Good afternoon, sir. Can you hear us?
Yeah.
Yeah, okay. So,
yeah. Thank you.
By this time, sir,
thank you, Doctor.
Yeah, without one of the greatest laparoscopic surgeon. So over to you, sir, without much wasting time.
Yeah. Thank you, Dr. Prabhakaran, for inviting me, and thank you, Dr. Muhammad Yasser, for the logistics. I'm sorry that I couldn't join you there in Nagarkovil, and thank you for giving me permission to come online. So the topic given to me is lap colorectal surgery, the tips and tricks. It's very difficult to say all the tricks and tips in one session for 20 to 30 minutes. Still, I try to include a maximum in my session. So you know the history. I'm not going to the details of the history and other things because already my previous speaker has alluded to the things. But when we started the lab colorectal surgery 20 years ago, many eyebrows raised, and there were a lot of criticism regarding the port side metastasis and dissemination, and the time taken for surgery and the steep bleeding curve which is required for the lab colorectal surgery and the extent of complication, and they were questioning about the long-term benefits, and the time has proved which is better. So I am not going to the theory part, and you can see the extent of resection you can do it laparoscopically, and the vision you are getting in laparoscopic surgery. And the radicality, you can see one of my recent pathological reports where for a colorectal surgery you are getting 54 lymph nodes, out of which 2 lymph nodes are positive. So it means that you can get better yield of lymph nodes in lap surgery than open surgery. For preoperative workup, you need to do a full-length colonoscopy, and the CA should be assessed, and if it is a rectal malignancy, you have to do a digital examination to assess the fixity and all, and you need to depend on the imaging, either CT or MRI. MRI is said to be better for the staging and to check whether you need to have a neoadjuvant therapy or not only for that, but there can be anatomical surprises while doing your laparoscopic surgery. So you study the imaging well in advance before the surgery so that you can avoid anatomical surprises. This is one of the anatomical surprises which happened in one of my earlier days, way back in 2006 or so. So when I was doing anterior resection, you can see that 2 ureters. That means that once you have seen one ureter, that is enough, and you can chop off whatever is coming in your way. That is not acceptable because you can have these abnormalities like that. So you have to study. This is the ureter on this side, and you have to study the imaging in the console before you go for the surgery. And because my talk is mainly on the tips and tricks, you can see that this table which I am using in my OT theater is having a tilt of nearly 30 degree head down and 35 degree head up, and it will be having a side tilt of nearly 25 degree. So if you don't have such kind of tilt, you may not be able to give a good tilt. And the lithotomy stirrups which I am using my theater is, I've been using it for the last 20 years. That gives your life very easy because you yourself can, without depending on the assistant, you yourself can manipulate the lithotomy and make it into any position by yourself. And I was talking to my postgraduates regarding the epidural anesthesia. For any visceral surgery, I used to be epidural for the patients. This is a practical experience which I gained. The epidural is, you give one shot of epidural just for the incision so that the bowels, the small bowel will contract so that will obey you. The bowels will obey your commands. And that will, you can pack the small bowels to a certain quadrant. These are the both sides I usually use for an anterior session. Contrary to what is the usual practice, I place the camera port in the right hypochondrium. My left hand port is in umbilicus, and my stapler port, right hand port is in the right iliac fossa, and I place 2 5mm ports on the left side for traction. So if in the case of a colectomy, means a right hemicolectomy, my placement is, the camera placement is in the umbilicus, Probably I'll be using a right hand for 10 mm so that I can use 10 mm clips for vascular ligages. The other 5 mm, other retraction bolts will be 5 mm. I usually do a extracorporeal anastomosis for colectomy, whether it is right hand colectomy or left hand colectomy or transverse colectomy. Now you can see this picture that I am doing the surgery, but the assistants are looking at different monitors. So it's better always to have two monitors so that the assistant can be relaxed. So they should not turn back and assist you, and that will improve your improve the assistance part. And also it's better you keep the monitors in two different sizes of the table so that if at all any additional leads or something else has to be there, it is easy that you can do it with this. So it's always mandatory to have two monitors at least in your OT table. And I prefer to do a laparoscopic ultrasound. Here the video is not working. Laparoscopic ultrasound before doing the surgery purpose. So I will examine the liver before the first step. And it's always better to give steep pendulum birth so that you will have a retraction of the bowel as good as you are doing an open surgery. Now, this is a video, but I hold this video at this point to show you some anatomical landmarks. Here you can see the DJ flexure. Can you see that? And here you can see the aorta foci. And here you can see the inferior mesotic vein. And here you can see the leportic artery. And I can see that this is the inferior mesotic artery, which is the only artery which is coming in the anterior aspect of the aorta from the DJ flexure to the bifurcation of the aorta. In this artery up, so that by this traction you can see the entire important structures here. Here you can see the leportic artery going like this, and leportic vein arises from here, and this is the inferior mesotic vein going up. And for a short course, the inferior mesotic inferior mesotic vein will be accompanied by leportic artery like this. So this is a very constant anatomical feature which is there, and everybody has to identify this. Now I am taking the peritoneum over the aorta, and you can see the hypogasthic plexus and can you see the hypogasthic plexus which is going down, that has to be pushed down, and the inferior mesotic artery has to be clipped and divided like this. You can either use metallic clips or the other one, and we can see that the leportic vein is going that way, and it's always better to prefer the leportic vein so that the conduit will be having a good venous drainage, and you can see the ureter just lateral to it. You can see the hypogasthic plexus here also. And when you go medial to lateral, there will be three yellows. Here you can see a orange yellow, here you can see a plain yellow, and another yellow is the ureter fascia. Then you can go medial to lateral and take the entire spleen flexure from that side, and then you will have to come down for the rectal resection or dissection, which is already my previous speaker was mentioning about the holy plane of field designed by Dr. R.J. And you can see that when you see the loose areolar tissue, you will have to stay anterior to the loose areolar tissue so that the hypogasthic plexus is well preserved, and when you reach the Valdez fascia, you will have to go anteriorly for the sacrum. And when you go to the lateral aspect, you have already seen that the peritoneum has turned blue. That means that your dissection has gone to that level event. and then the dissection, the final dissection is happening between the pelvic structures and the pelvic muscles and the rectum, and usually we'll get a distance of nearly 4 to 6 centimeters from the appearance of the pelvic muscles till the point of division if it is a very low lesion. So we have to go in between the pelvic muscles and the rectum so that we can divide the rectum very low. Here it is a very low rectal lesion. We can digitally palpate the length of the rectum to be divided, and you can use staplers. The angle of staplers I'll be alluding to in the next slides. So these 2 staplers most probably sometimes we can achieve with 2 staplers even. Now you can see the rectal stem pelvic muscle is the internally artery, the vein, and the lateral pedicle, everything you can see there, and coming up. That is hypogastric plexus on that side, that is the hypogastric plexus on this side, and that is the ureter, and then you can go up to the, already you have we dissected the spinning flexure. Now you are the conduit is ready to be prepared. The pollen is taken through a small incision, pressing is applied, and it's always better to keep the pressing at the entry level and the anti-mesenteric border, so that will aid as a marker for your tilt of the colon when it is put back into the peritoneal cavity. And we always look for the orientation of the colon, otherwise there can be distinct side and you can have acute intestine obstruction. Now the stapling is happening, you can see that the colon is so redundant that, and it is vascular also. When there is doubt about the vascularity, actually we have to look for the veins first, because it's not the artery which is giving you the clues. The vein will be black instead of the purple color. The vein will be, if the artery has gone, the vein will be showing a black color. That is a clue regarding the vascularity of the colon. Even if you don't have this immunofluorescence in your theater, you can keep a trail there and come out. Now, a lot of people are using uterine rotaries of female patients, but you can use opened bowel forces just to rotate the, you don't have to have heavy instruments for this one. And the medial to lateral spinning flexure mobilization we can achieve by looking at the color of the Gerota's fascia. Gerota's fascia is golden yellow, and you can see that lobulation of the Gerota's fascia. The fat is lobulated in case of Gerota's fascia, and you can see I'm opening the peritoneum just above the pancreas, and you can see the pancreas is orange yellow, and you can go just above the orange yellow thing. And inside the peritoneum there, and that is a clue. So 3 yellows here: plain yellow, orange yellow, golden yellow. So that is how you go to the medial to lateral aspect in splenic artery mobilization. Now, nerve injury, there are many areas where nerve injury happens. One is at the ligation of the inferior mesenteric artery, where hypertrophy is very close. And another area where the middle, you can see the hypogastric plexus in the middle rectum, you can see that is hypogastric plexus. And when you pull the rectum down, you can see a triangle there. That means that is giving a branch to the rectum, that is the branch, and the nerve can get tended like what you are doing in polycystic time, where this ability get tended. Here also the same mechanism can happen, and we have to be that is the hypogastric plexus, that is the nerve to the rectum, that is the bladder fibers. So you can leave that part and ligate close to the rectum so that the bladder fibers can be saved. And the seminal there is always a bleed on the junction between the left lateral aspect, where very cautious about dissecting there, and you can see that once you dissect middle, you can see the prostatic capsule there. Can you see that prostatic capsule? Now coming to the angle of dissection of the angle of resection of the rectum. When you apply the staplers, first means your staple will be coming to your right hand port, and you will be applying the staplers from right hand port, and you have restrictions in the flexibility of the staplers. Then what you can do is that you just pull the rectum opposite you, so that this can be made right angle to the rectal tube. And if at all you are applying two staplers, it's always better to apply two angles. I can show in this video that it's two angles. One is you are taking the rectum away from you, and the digital examination is happening. The stapling away from you, and the next staple line towards you, and next staple line towards you, so that the rectal stump will be carrying enough vascularity that will be in the shape of a Chinese cap. And there is an instrument called Goldfinger. If you are not accommodating the rectum as a whole, you can put another port there, and you can use even a Goldfinger to retract the rectum. That is the Goldfinger, which is being used, so that can accommodate to the staple line.
Madam, tell me.
And there can be there are some noises coming. There can be some dog earring, even if you maintain the principles of division of the rectum, and there can be dog earring of the rectal stump. That is a dog earring which has happened, and any dog earring that happens has to be stapled like this. So dog earring is not allowed because that will go for a gangrene, and that will cause leak post-operatively. And as I told you, there is always a distance from the appearance of the pelvic muscles towards the end, and you will achieve nearly 4 to 6 centimeters to that level. Here I am going between the pelvic muscles and the rectal wall, so that you will get more length there. You will get more. So most of the time what happens is that people will be stopping when you see the pelvic muscles, but there is enough length beyond that also. So this is one of the surgeries I had done nearly 14 years back, and you can see the prostate here, and you can see the pelvic muscles as buttocks here, and you can see the rectal stump here. This picture itself shows that how low the rectal stump is, and this is the same patient's picture. And you can make the anal canal into a tube, so that the staple will be accommodating with the tube, and you can see the donut is having skin even. And the pathology report itself showing that donut is having skin, anal skin free of atypical cells. But this patient had a good continence, so that's what, if you are doing a proper dissection, you will be having good continence. I'm not going to the trials, and my previous speaker was talking about the distal marginal safety and talking about pushery. But after that, when meta-analysis came in, is 1 centimeter rule distal dissection is the rule or not? And in that paper, they are saying even 0.5 centimeter is enough. So the importance of digital rectal examination I'm not going to details. Now, some preoperative mix-up can happen during dissection. Here is a already polypectomy done for rectal polypectomy done for this patient, and you can see the tattooing of the patient, and we have done the enough mobilization of the rectum, and we are applying a stapler well below the tattooed area, and this is second stapler which is being applied, but it was so close to the anal verge that when we try to do a PR, and you can see that the examiner's finger is coming through the rectal. Can you see the finger is coming through the rectal wall? We try to suture that one with this one, but that didn't happen. And that tumor is taken out and prepared the colon for anastomosis. And resected as I have shown in the previous this thing, and not password forwarding because it can get stuck. So that is resected off, a piercing is applied. And the anvil is attached, and because of I thought that the suture itself will take care of the rectal stem. When we try to do the anastomosis, once again we try to put the finger just to introduce the stapler, and you can see that the finger is coming again. So we thought of converting into anal anastomosis, and we took the colon out through the rectal stem and pulled out through the rectal stem, and you can see the rectal margin we had. It was so close to the anal skin. Still we did a anal anastomosis, and that is the margin we already had. This much of margin, 1 to half centimeter. And we did a anal anastomosis. And even in this patient, actually patient had that is the anal anastomosis. And this is the postoperative video of the this patient, and you can see how close to the anal skin the staple line is. That is the anal skin and that is the staple line. And another troubleshooting I will show you while I was doing it anterior section, low anterior section, applied stapler, good staple. Applied, second stapler, and the anvil is the pointer is coming, anastomosis is happening, and we usually reinforce the staple line before we fire. And after firing, when we check the jacuzzi test, you can see that the air is coming, bubbling. So what happened was that initial stapler line, though it was closed, the first stapler, the rectal stem stapler, though it was closed, it was showing some leak, which we didn't recognize. That was the previous suture which is done, and you can see that the air was coming through the first stapler. Can you see that? The air was coming through the first stapler. So what you will have to do is that generally people tend to do a colostomy and come out, but we tried to close this one and we avoided a colostomy. So 3 sutures we put and we avoided a colostomy in this patient. It's taking time to go to the next slide. So if you want me to stop, I'll be stopping here. Otherwise I'll be showing a right hemicollecting video also. This is follow vesical fistula. If you want me to show, this is small clip. Small. If you want me to stop.
So yes, sir, we are running short of time. Next we have Felicitations program.
Yeah, I'll be stopping.
Yeah.
Thank you.
It's very useful actually, but unfortunately we had to stop.
Can you please be louder?
Sir, as we are running short of time and the felicitation program is also on the so it was very useful, sir. Thank you so much for the excellent demonstration, sir. Thank you. Thank you.
I request Professor Dr. Prabhakaran sir to honor the chairpersons.
Can I sign off?
Yes, sir.
Thank you.
I request Professor Dr. Rajkumar sir to join the chair. I request Dr. Sundaram sir, Professor Dr. Sundaram sir to come on to stage to chair the session, and also I request Professor Dr. Nagalakshmi ma'am to come on to stage to chair the session. Sir. We welcome Professor Dr. Jeswan, Director, Institute of Surgical Gastroenterology and Liver Transplant, Stanley Medical College, to give a talk on standardized techniques for colorectal anastomosis, prevention and management of leaks.
Professor Jeswant was my senior at Madurai Medical College. I don't know whether he remembers me or not. He was with the Satyavan sir unit.
Yeah.
And I was in Jyothi Ramalingam sir's unit. Even then he was a very erudite person and very calm and well known for his surgical prowess. Over to you, sir.
Yeah. A very good afternoon, everyone. Respected chairperson, senior professors, students. So, I thought before going to the actual topic, because all these things you can have from either Google Party or DeepSeek, Andy or ChatGPT angle. So as for the other sir was asking to genetic test why we need to do colonoscopic screening at earlier age. Nowadays we are seeing more and more malignancy cases even at younger age. Any malignancy, colorectal, every malignancy. So even genetically determined patient also, because of the environmental factors, the macro environment inside our body or outside the body, the constant assault we do on our environment system, predispose for malignancy changes. So even if genetically determined cases, they are developing very early. So we have to screen for
millions very early. Unfortunately, these all are man-made. These can be prevented. If we preserve gut health, we can prevent malignancy or prolong the occurrence of malignancy. I will tell you how. For example, you know, most of you where I am coming to. The conjunctivitis is normally caused by what organism? Virus, adenovirus. Right? Recently, they did a study in Institute of Ophthalmology, Chennai. Almost more than 90% they found enterovirus. They thought they were wrong. They didn't publish. Then they told them to publish, and they published also. Why enterovirus went there? If you study the 7 of infertile people, you can see enterovirus. Why enterovirus goes there? The native environment is damaged. They move to other places. You can see wherever this infertility, millions and so on, so on, so on. Unless you maintain the milieu, you are bound to have all these problems. Being born in this beautiful world, we don't deserve to suffer from millions at a younger age or from infertility at a younger age. Please take care of your environment, especially gut health. There we are coming. Because we get our genes from our parents. 97% of genes can be modified by microorganisms. mRNA is heat resistant, all the DNAs can integrate with us, it can modify. That is how the genetic modification occurs. Do you know how much protein we need per day? You must say 1 to 2 grams and all. These people in Papua New Guinea, Kitao people, they take less than 10 milligram per kilogram body weight. Less than 10 milligram per kilogram body weight of protein. But they are very active, they are muscular, they have a normal albumin level. How? We don't have urease. What happens? The urease containing bacteria enters the colonocyte and split the nitrogen, splits the urea and send the nitrogen back. This is how our nature protects us. If we can keep the environment inside outside, if we more with nature, invariably more than 80% of diseases can be either prevented, treated, or it can be delayed. Why I'm coming to this is because one of the causes is prevention of the gut leak. Gut mucosa is nourished by colonocyte, the short chain fatty acids. So all of you know. What I do, by patient, I ask them to take plenty of fiber diet, fermented food, especially padai choru, and ask them to walk also. That's a very good rehabilitation. Unless they show me they increase the albumin level from the time of admission, I will not do surgery. Because physical activity is the best stimulus for liver. So I was answering your question only. Why that went to the gut environment and all. Having said that, yeah, go to the actual this one. So it is about colorectal anastomosis. They are more prone for leak, 5 to 20%. I'll be happy to do liver resection or reproduction without leak and all. But this is one thing I am very much worried actually. Consequences, of course, you know, increased morbidity, mortality, prolonged hospitalization cost. So when the patient develops complication, it not only affects the patient, it affects us also. The double-edged sword. It kills both of us. As all of you know, in Indian situation, the life expectancy of doctors is 5 to 15 years less than general population. That means something wrong within us. So these are factors, many factors contribute to that. Subject is to discuss standardized techniques to prevent and manage leaks. So patient-specific factors, disease-specific factors, and surgical technique. Nutritional status, I told you, you don't have to maintain nutrition for more than, within 2 weeks you can maintain nutrition. Give them nutrition and let them take whatever they want, no specific nutrition, and makes them walk. That will improve both. And anemia, of course, control that, uncontrolled hypoglycemia, and intraoperative hemodynamic instability, you know that depends on the surgeon, meticulous surgical technique. Smoking has to be stopped at least for 6 weeks, and obesity all of us know. Having said that, the samosa and this they are giving, no, jalebi, very sorry for that. That destroys the gut health. ரெண்டு. ஸோ கேட்டு வருவாங்க, நான் தண்ணி அடிக்கல, சிகரெட் பிடிக்கல, அது பிடிக்கல, எல்லாருக்கும் நான் உதவி தான் பண்ணேன் என்ன. ஆமாம், அப்புறம் எனக்கு இந்த வியாதியில் ஏன் வந்துருந்தேன். நீங்கள் உங்களே பார்த்துக்கல, ஸ்லோ ஆர் யூஆர் கமிட்டிங் சூசைட். பிளாஸ்டிக் பாட்டில்ஸ் அது கேட்டால் சொல்லுவேன், வாட்டர் இஸ் பீயிங் சப்ளைட் இன் டாக்ஸிக் கண்டெய்னர்ஸ். When you take water in plastic bottles, close to 90,000, it is proved, study was proved, 90,000 microparticles enters your brain. If you avoid this, only 5,000 enters. As we grow older, we get dementia, memory loss, everything. So what we need that, yeah. So it is not only that, slowly we can avoid this, we can carry water, we have been doing all these things. ஸோ சிம்பிளாக சொன்னால், அளவுக்கு மீறின அலங்காரமும் ஆடம்பரமும் அழிவுக்கு வழிவகுக்கும். வாட் வி ஆர் லீவிங் பிஹைண்ட் ஃபார் அவர் யங்கர் ஜெனரேஷன், தட் இஸ் மோர் இம்பார்ட்டன்ட். ஸோ மெடிக்கேஷன் தட் இம்பேர் wound healing, we talking about all biologicals, biostimab and all can cause severe leak, radiotherapy, inflammation, Crohn's disease or unhealthy gut, dysfunction, colitis and so on can all cause increase the leak rate. Surgical technique, yes. The more the meticulous, more the tissue will respect us. It's adequate perfusion and tension-free anastomosis. So, the atomic bowel clamp should be applied with a minimal force you talk to the lumen. The importance of adequate visualization must be recognized and proper use of diathermy, avoid the coalition diathermy at the edges. Bleeding from the cut edges of the bowel, that should be the pulsatil bleed, we can be sure. And palpating the pulsated artery, that we can be sure. Can do Doppler sound or ICG. ICG also can be subjective or objective. How soon you do the testing, from how much distance from the bowel, everything is important. Not yet standardized, but it will be standardized in future. Eliminating tension. Issue of reaching becomes the more pronounced for left-sided and pelvic anesthesia. You know, often it doesn't reach the lower end. If it doesn't reach, what will you do? So you have high ligation intermesenteric artery, inframesenteric vein. You got a transcameral mesentery also with the division of the middle colic branches. Next step. So all of you are aware, we can do coloplasty with ascending branch of left colic artery or middle colic artery, you can come up to the neck and all those things and all. So properly, if you preserve the marginal artery, it can reach down. Of course, whenever you plan to divide the middle colic artery, do pretest, something, apply vascular clamp or bulldog clamp and see before dividing that. If you divide the middle colic artery, always ensure the distal vascularity is preserved. So you can divide that mesocolon also to straighten that. Of course, dividing the left colic artery, other arteries can be done depending upon the preserved vascularity. That you can decide on the table also. So still it is not coming. You can bring it like this, retroileal. You can make a window and bring it like that. Still it is not possible. Bring it, divide it, rotate it and bring it. Some of the vascularity is gone, or because of tumor you have to research so much. Rotate it and bring it. I haven't done these things. I have divided middle colic artery. So these are the various anastomotic configurations you can do based on your experience and your convenience, what way you have comfortable with that and all. So this is the commonest technique, of course not for colorectal, I use for right hemicolectomy, double stapling technique. Very fast, it's very secure anastomosis. No need for any DT also. So when you do surgery, you should do with the idea of not keeping the DT. When you have that habit, you will make sure you do perfect anastomosis. You do perfect hemostasis. Keeping DT is like stabbing the patient under anesthesia and leaving the knife there. Not only knife, tying something the weight in the knife. Imagine that, how much trouble it will cause to the patient. Not only that, it will erode the vessel, it can erode the anastomosis. It is a foreign body. The foreign body can delay the peristalsis. All these things can happen. To keep that in mind, to do perfect surgery. So this anastomotic, of course, staple, now 2 rows, now we have 3 row staplers also to prevent leak as well as the maintain the vascularity. You have to familiarize with these techniques. So as I told you earlier, gentle tissue handling, spacing sutures appropriately. How much space you will give between the edges and between the adjacent? Any idea? Yeah, thickness of bone, but large will normally 4 to 6, even distance is around 3 to 5 adjacent distance. So all of us know it is the submucous strongest layer, we have to incorporate that. And tie knot sequence without causing, you should not tie too tightly also, not very loose also. The vascularity, impaired vascularity is the most dangerous thing. Otherwise, if it is loose also, the mucosa will get, mucus move towards each mucus very fast and all, the coagulum will also form. So it's a Baker type anastomosis, but let to know the various type of anastomosis. So create a satisfactory lumen, so adequate size of the stapler, preserve the blood supply, that's why they have introduced now 3 stapling technique, for a good hemostasis, yes. Keep tissues free of tension. Of course, this is about ligate the inflammation of the road, then inflammation vein, then mobilize the splenic flexure. It is very slow. I do away from the routine. Sometimes female patients, low anti resection, the one colorectal anastomosis, I do transvaginally so that the sphincter is not damaged. After doing the colorectal low anastomosis and all, sometimes if I feel there is tension, I do the perineal incision. So we mobilize from above, some will mobilize from below also. These are not given in the book actually. That's I practice sometime practically. There's one video showing the transvaginal anastomosis there actually. Can you move forward? So we can do leak test and all, but leak test is not the foolproof to prevent the things. When small debate will open up, actually it will close actually. So for our satisfaction, we can do leak-proof test, but it hasn't prevented the leak. But if there is a leak, we have to suture it. That way it will be useful. This one lady with rectal gist after chemotherapy, it was static, and she was not willing for APR other than this colon anastomosis. So we did transvaginal excision and did colon anastomosis. Both done transvaginally only. The vaginoplasty after the anastomosis. So leak test can be done using air leak, saline leak, methane leak test. Another one of the important useful techniques is endoscopy visualization. ICG imaging, color Doppler flowmetry. So it is more than a air leak test. Can visualize the integrity of the staple line internally and assess for bleeding as well as area of ischemia. So this is a grading. So it will be very useful actually. So you can repair it, or we can go for refashion it, or we can go for covering ileostomy or collagen depending upon the ischemic status. Diversion stoma. When we do temporary diversion stoma, I don't fix it to the rectus sheath or peritoneum. Just fix it with the skin. So it will be very easy to close it. Even if there is some prolapse, you be happy because there won't be any additions. Usually I don't remove the fat also. Unless the patient very fatty, lower abdomen fat, and that remove the layer of fat below the corpus fascia, so the stoma will come up to the skin. So these are the things they are mentioning. I don't follow that. Maybe sometime I will use momental wrap actually. Other things I don't follow. So early detection is, all of you know, fever, tachycardia. You can make use of CRP as well as other tests also. CT scan is the best investigation if you have any doubt. The grade is like pancreatic leak only, grade A, grade B, grade 3. So you have to go for surgery that needs percutaneous drainage, that can be treated conservatively. So, my ladies and gentlemen, the take-home is good vascularity, no tension, meticulous technique, early diagnosis. More than that, keep your gut health, live happily, live healthy. That's my only aim, nothing else. We can prevent almost 80% of diseases. Thank you very much for patient hearing.
Thank you, sir, for your enlightening lecture, especially that on the preservation of gut health and preservation of the environment. Thank you very much.
Having said that, oh, Dr. Bennett is there. I didn't see him. Yeah. Middle bench, huh? Thank you. So, after 15 years, we are organizing the Indian Society of Surgical Gastroenterology. I am the organizing chairman. The scientific, organizing secretary. The scientific team has gone into very details. The team is G Oncology, so that young surgeons, students will be benefited. Almost every point, everything will be useful for me. I request you, all of it register and come in large numbers, and I will get you the consent rate registration also, for MS students especially. So it will be very useful. We have gone extra efforts, all of us have extra effort, daily we are discussing how to go about and all. The things will go like this, especially CME, one nice video session, then one MD TT, then nice discussion like that only. Crisp. All people in the, top more people will be there in the respective field. So I request all of you come in large number and get benefited. Thank you very much.
I request Professor Dr. Padmanabhan sir to honor our speaker.
So we are roommates, will be MCAs.
I request Professor Dr. Prabhakaran sir to honor our chairperson. For next session, I request Professor Dr. Bennett sir, Dr. Krishna Bharat sir, Dr. Aravind Menon sir to occupy the chair. As surgical technology continues to evolve, incorporation of robotics into colorectal surgery has transformed the way we approach complex procedures. Precision, enhanced visualization, and ergonomic advantages have made a robotic platform an increasingly valuable tool in modern colorectal surgery. We welcome Professor Dr. U.P. Srinivasan sir to talk about stepwise approach of robotic colorectal surgery, technical pearls and learning curve considerations.
Good afternoon and all. At the outset, I would love to congratulate Professor Saravana Bhoopathi sir on his superannuation. Why I should congratulate is that getting relieved of this service will be a boon to anybody who is working in the service. So just a small presentation from me. World is moving towards robotic surgery. There was a discussion between minimally invasive surgeons in France, wherein I happened to be a part, where they were discussing that in another 5 years from now, almost all the procedures, even mastectomies, will be performed robotically. That was what is going on around the world. So with that small audio, I will go into without much audio, I will go into my topic. My topic is a stepwise operative approach to robotic colorectal surgery. This is a very easy topic comparing to all the extensive discussions that was being put forth by all the doyens before me. Because I am just going to show you some one video and some techniques which I think over a period of time I think that it will be helpful for anybody who is going to take robotic surgery in near future. So there will be some technical tips and tricks from me also. So robotic colorectal cancer surgery offers a lot of advantages when compared to traditional open and even laparoscopic procedures in the form of an enhanced precision as a result of 3D high definition vision and filtration of tremor. There will be a greater range of movement of motion for the instruments with that 7 degree of wrist movement in the robotic arms instruments, and as a result of which an improved dexterity. All this culminates in less blood supply, blood loss to the patient and less pain, thereby culminating in a faster recovery. So I'll be taking this in this stepwise approach. Preoperative preparation, though we are going to talk about any technicality of any procedure, all we need to keep in mind is basics are basics. So we have to adhere to the basics of this preoperative preparation, patient evaluation, careful selection of patient, and the bowel preparation, which have been alluded to well by the previous speakers. So for any surgery, patient is going to be the key. So we have to discuss the fears and concerns openly with the patient and the attenders, ensuring whether they are understanding the procedure and the potential outcomes, whether they are well aware of. So as I mentioned, thorough bowel preparation is the key to any minimally invasive surgery, be it laparoscopy or open surgery, open as well as robotic surgery. In a fully loaded abdomen with the intestines fully loaded, you will find it very difficult without the haptic sensation, that haptic feedback that will be absent in the robotic surgery. When you try to push the bowel that is loaded without this haptic feedback, there is high chance of causing injury to the bowel. There ends the procedure. So ensure thorough bowel preparation, and we have to meticulously review preoperative imaging. Jailal sir was very kind enough to extensively discuss about that preoperative imaging, and preoperative team huddle. That is, we have to have a team huddle between the surgeon, assistant surgeons, and the anesthetist, OR team, scrub nurse, everybody. We should have a preoperative discussion about what is going to happen and the plan of action that is going to go. So the ergonomics is the key to any minimally invasive surgery. So as I told you, careful selection of patients based upon the tumor location, stage, BMI of the patient, and the history of any previous abdominal surgeries. So the point that I am going to give here is that it will be beneficial. Robotic surgery will be beneficial in patients with narrow pelvis as well as obese patients, but it may not be beneficial, or other modalities will be more beneficial than robotic surgery when there is an extensive tumor spread or dense adhesions. So we have to carefully select the patient beforehand. And so positioning of the patient is the key, one of the keys here. Supine position with specific tilts. For a right-sided colectomy, right side up, and Tirunelveli position with left side up for any pelvic dissection, so rectal cancers. And since the position is going to be like this, patient's chest and legs should be securely strapped. This is very important because during a robotic surgery, there will be everything will be cramped there. The patient will be surrounded by lots of robotic arms all over covered, two assistants, one nurse, everybody will be sitting there, and we will not be in a position to see whether the patient is slipping down or not. So this point is very important. So port position, port placement, as in any other case, it's new peritoneum up to 12 to 14 as per your preference. Trocar placement, the camera port and working ports, most of the robots today, nowadays, they are like 12 mm camera port for Da Vinci, and nowadays we have, even for Da Vinci, we have 8 mm, and other ports are like 8 mm here. So each ports, as you can see in the picture there, each ports, I could not move from here. So as you can see, the camera port should be strategically placed so that it will be like this one. Sorry. So it will be like at a strategic position, stable, and where there should not be a need to change the camera port, because in robotic surgery, once the table is fixed and the instruments are docked, we cannot tilt the table. So everything should be pre-planned. Nowadays, the recent Gen 5 Robo Da Vinci is coming, that will be having a tiltable table. But as of now, there is no tiltable table, so we have to be very careful in positioning the patient. So the strategic positioning of the camera port and all the rest of the ports, normally we keep it in a diagonal manner for Da Vinci and any other robotic platforms. Sometimes we may use the diagonal, linear or diagonal circular thing like this, semicircular orientation may also be kept there. So assistant ports should be 6 to 10 centimeters apart like this. Once the camera, all these things will be done before docking. All the ports should be placed like this, and then we have to dock. So docking is the key in any robotic surgery. Once you dock it perfectly, the surgery is going to be like a cakewalk. So take time in docking and train you should have a trained or people who will be able to dock as quick as possible. So thereby it will reduce the overall surgery time also. Overtime, not the surgery time, overtime. So this multi-docking, what I mean by multi-docking is that once docked, we have to change for upper abdominal. If you want to do a splenic flexure mobilization using some robot that cannot reach in the same docked up position, then you have to change the docking. That is called as a multi-docking. But the recent XI robot, Da Vinci XI, since it has only a boom that is above like this, you need not have to do a multi-docking. You can easily rotate it and you can do the whatever if you want to do an upper abdominal surgery or a lower abdominal surgery, that can be done in the same docked up position. So, as I already told you, the dissection, because of the enhanced visualization and 3D HD, you can utilize the zoom and focus. This is an interesting thing. You can also do during laparoscopy, if you take your scope close to the structure, you may be able to see it better. But here, when you take the camera closer to that structure, you will have an enhanced view. The structure will be as if it is grown in size. So that is very much useful in doing some finer dissections here. And key to surgery is that maintain a clear field, ensure perfect hemostasis. So as we all know, bleeding will cause lesser visualization of the field because of the light absorption. And we should have an instrument mastery. You should be very well enough to utilize the end-wrist articulation. You should not be using a robo like a straight instrument like a laparoscopic instrument. It has a 7 degree of motion. So we will be adept in doing all these articulations, and should be familiar with the variety of instruments. That is very important because these are very costly instruments. Each arm is going to cost you like 60,000, 70,000, but actual price they will be giving is like 1.5 lakhs, 1.6 lakhs. So if you are going to complete a surgery like a rectal cancer surgery, if you are going to take 4 instruments, the extra cost is going to be like 2.5 lakhs. If you can finish it off using only 3 instruments, you can reduce it to 1.5. So that is a very big difference that is going to happen there. So you should know for this particular surgery which are all the instruments that I am going to take. with this familiarity, you can reduce the cost of the procedure. So instrument exchange should be smooth and efficient. That and all, it depends upon the training that was being given to the OR people. So intraoperative dissection techniques, here one thing you have, as I already told you, there will not be any haptic feedback. So you should know the tension without haptic feedback. So touch sensation will not be there. So always rely on the visual cues like blanching and stretching. So once you, that will come over a period of time. When we do 2 or 3 cases, we'll definitely come to know that this is going to happen. So traction and counter traction is the basic of any surgery. So you should be able to do it with 2 robotic instruments. And all these things are key in preservation of the important structures like gonadal veins, ureters, and nerve preservation. So nerve preservation, we need to preserve the hypogastric plexus of nerves so that you can avoid damaging the bowel and the sexual functions. So these are the common steps involved in any colorectal cancer surgery. So setting the small bowel apart, that I have already told you. Once you put the scope in first, before docking the robo, you should you have to utilize the robo as a laparoscopic platform. Just put in the camera, put other instruments after placing the ports. Keep the, after tilting the patient, putting the position, keep all the small bowel away. Better if you are going to do a rectal cancer means you should keep it on the right iliac fossa and bring it to the subhepatic region. That will be helpful for you in any rectal surgery. So first thing you have to do is, after keeping all these things, setting the small bowel apart, vascular control, achieving a vascular control early in the procedure will help with the reduced blood loss. And medial to lateral dissection is the rule, like for all the bowel surgeries, especially large bowel surgeries. So mobilization of the colon and rectum, preserving vital structures, as I have already alluded to. So one procedure I'll be dealing in a little bit of detail. So rectal cancer, as Padmanabhan sir was telling, TME along all the embryological planes is the key to this surgery. So as I already told you, high vascular pedicle ligation should be the first thing we have to do. It could be high or low. There are studies supporting both. Low is enough as of now. When there is no obvious big nodes in the root of the IMA, you can just go and do a low vascular ligation. So splenic flexure mobilization, it's done for left side resections to ensure tension-free anastomosis. But I want to give my experience on this, because I would have done nearly 30 so far. That's my experience, that's all. But I have done splenic flexure mobilization in only 2 cases. Rest of the 28 cases, I never required splenic flexure mobilization. So what we need to do is, medial to lateral dissection should be done properly, and in cases if the colon is not reaching, you just ligate the IMV, then it will reach most of the times. You just make sure that it is tension free, that's all. You should not mandatorily go and do a splenic flexure mobilization in all the cases. That is not required as far as I am concerned. And there are papers are also there. I have published this in a very small journal, which I cannot tell you because it is very small. So transection is the next part. Transection can be done using robotic or laparoscopic staplers. Robotic staplers, since they are very costly, there is one stapler called as Sure Form. It is very costly. So that will be useful for cases where you are using minimum of 6 staplers. When you use minimum of 6 staplers in a case, then the cost effectiveness will be there, as if you are doing for an open case. That comes in only for lung resections. So for lung resections, they will be using like 6 to 24, even in some cases 24. They will be like clipping single vessels, individual vessels in the lung. So here robotic staplers, though it will be helpful for us, laparoscopic staplers will do the same work. Port positioning, as Baiju sir was showing, that assistant port for a robotic surgery, it's surgeon's preference, but they say it should be 5 centimeters above the diagonal line of the previous ports, and 1 or 2 ports can be used depending upon the difficulty you face. So when you use a stapler, like in an obesity surgery, you can put the stapler through the right hypochondrium 12 mm port. Otherwise, you can use, once you are decided that you are going to put a laparoscopic stapler, you can do it by undocking one arm, and you can put a scope down here in the suprapubic region after making a new port there. So specimen extraction can happen through a phalansteal incision or a lower midline incision, whatever way, but the tumor wound protector is a very good tool here. Thereby you can just avoid spillage of the tumor cells into the open wound. Some people are doing this natural orifice specimen extraction transvaginally also. Very rarely people used to take this natural extraction and natural orifice extraction through the anus also. There are some techniques are also there. So going into the anastomotic part of this, they have shown how the anastomosis is being done in other laparoscopic procedures. So the intracorporeal knotting is the one thing that can be done very easily in robotic surgery. We can do a robust anastomosis using robotics. So the main advantage here in intracorporeal using robotic is that there will be less bowel manipulation and potentially reduced post-operative pain and faster recovery. Anastomosis could be side to side, end to side, end to end. Jaswant sir was telling. Extracorporeal anastomosis was also shown by Baiju sir. So ICG, I don't think it will be of any use as of now. Once it's available freely, I think only one company is producing ICG in all over India. Once it comes freely and when everybody is adept in doing these things, then we can just start using once it is being standardized. I was having the videos and all those things and I lost it because my laptop crashed. This is the last minute preparation. So just a small video of low anterior section in a 58-year-old gentleman post RT. So, as I told you, bowel was pushed to the right side, and the key is to find the proper plane. For TME plane, proper plane has to be identified. The color of the fat is one thing that can help you with finding the proper plane. So whatever the fat that is with the rectum will be like a little lesser yellow, and the rest of the fat will be like slightly orangish in color. So whenever you try to stay between, first step is to go and find out there you can see now you will be able to see the hypogastric nerve. So the nerve is visible there. So once you see the nerve, always stay medial to both the nerves, both left and right side nerves. If you stay medial to the nerves, then you will not be injuring any important structures, especially ureter. So I am dissecting the IMA there. So for this patient there was no node. As for MRI and all those things have not shown anything, but when we dissected that, I could make out, my plan was to do a low ligation, but there was a small node that was there at the root, which I did a berry picking that turned out to be a reactive node. So you can see the endo wrist being used comfortably there, like our own wrist. So you can see the node that is coming into view there. That's a flat node, unlike a malignant node which will be round normally. This patient specifically, he wanted to preserve his sexual function. So we did not go close to the root there. That thing is the IME that is slightly bleeding. And one thing, if you observe here, I'm using only the bipolar and monopolar here. No big energy device is needed for robotic surgery. God knows how this bipolar and monopolar behaves very well in robotic surgery. The same machine, if you use for laparoscopy and open surgery, you may see a lot of bleeding. So IMV. My assistant wanted to use this harmonic. Dr. Gnanasayer used to assist me for all the cases, so. And now, again, concentrating on the TME plane here, you can see a nice, when you stay medial to the nerve, you will easily go into that free areolar tissue that is seen there. So one thing you have to keep in your mind is that the rectal fat belongs to the rectum. So this is there were some adhesions on the left side which I have removed before. Before starting this case, laparoscopically the adhesions were removed. So this is the left side paramesocolic dissection. The tumor is coming into view now. This is the dissection between the bladder and actually you could see the seminal vesicle now. So now we will be dissecting between the Dina Nullius fascia. Now you can see the nerve has come this side, on the right side. So actually I have seen the ureter, but that is not seen here in this picture. When you stay medial to this, you will not be seeing the ureter and other important structures. So ureter is actually seen in that before this, on this peritoneum. This is what I was telling about, that zooming and focusing. When you go close, the things will become bigger into vision. So you can see the ischiococcygis part of the levator ani there, and we are going down and we will reach the floor of the levator ani. So we will reach that, and the rest of the procedure will be like we will put the stapler, and circular stapler will be introduced through the anus, and anastomosis will be completed. Regarding keeping the stoma, I always do that leak test. Once I am convinced with the leak test, I will not keep a stoma, and I will not also keep a drain. So far I have seen a leak, but many a times when we concentrate on the not injuring that marginal vessels, so 3 more slides, we'll stop this video, we'll go to the slides. ஏதோ டைமிங் செட் பண்ணி வச்சுட்டாங்க, தெரிஞ்ச பசங்க தானே எல்லாம், சார் ஒன்றும் சொல்ல மாட்டாரு, நாங்கள் எதையோ அமுக்கிட்டானுங்கன்னு நினைக்கிறேன். சிவனும் நானும் பைக் எடுத்துட்டு எங்கேயா சாப்பிட போலாமான்னு நினைச்சோம். ஓகே நெக்ஸ்ட் ஸ்லைடு போயிடலாம். இல்லை வராது, இதுதான் உங்களுக்கானது முக்கியமானது. ஸோ லேர்னிங் கர்வ், ஸோ இட் ஷுட் பி a structured training with a proper mentorship. Always start with simpler cases like right colectomy, segmental resections, all those things. Always start with small cases that will help you with adapting to that absence of that haptic feedback. And when we go into like a high volume center in rectal colorectal cancer will be like 30 plus cases in a year. And important thing you have to know is to troubleshoot. Whenever there is something that happens during a robotic surgery, you should know basic troubleshooting thing. Anyway, you will be having the people who are from the company, they will be there during the initial days. Never hesitate to convert. Conversion could be a laparoscopic conversion or an open conversion. And as I told you, ergonomics for the assistant is very, very important. If the assistant is not happy and focused, you may not be able to complete the surgery in a proper way. So challenges to be mindful of is that again and again lack of haptic feedback, the cost, longer operative time at least during the initial learning period, and the docking time. Once the OR team is well adapted in docking, then that will also be reduced. We have done docking in 6 minutes also, once everybody in the theater is well versed with that. And post-operative care, ERAS protocol is followed. Monitor for complications. Surgery successful patient is not living means that is not a good thing for any surgeon. So even if it is going to be a robotic surgery, technique wise it is far superior, artificial intelligence, all those things. When you don't have a live patient or a patient with patient who is having high morbidity when he is out of the surgery, then whatever program that we are trying to start, that is not going to be of any help to the society or to ourselves. So by focusing on meticulous planning, mastering the robotic platform's capabilities, adhering to oncological principles, and continuously refining techniques, surgeons can optimize outcomes for patients undergoing robotic colorectal cancer surgery. Thank you for your patient listening.
Hello, sir. Sir, I have a question for you. Excuse me, sir. Sir, do you find any change in the TME specimen comparing robotic versus laparoscopic or open surgeries, like nodal yield wise or the specimen itself per se? Do you find any change? Is the robotic is better than laparoscopic, or what do you say?
See, the principles of surgery should be followed in whatever method you are doing, be it laparoscopy or robotic. Our principle is to follow the proper TME plane. When you do it by robotic or laparoscopic, then there is no difference will be there. But if you are if you are trying to do something faster and try to achieve something by finishing the case early without following the principles, then there will be definitely a difference. As of for me, I don't think there is a difference between robotic and laparoscopy. Whenever the principles of whatever the surgery may be, whenever it is followed, there is not any change. But I have seen less blood loss during laparoscopy, during robotic surgery, because of the larger view, focused view, you can see that whatever bleeding that you saw there, it was even before it starts bleeding, it will be coming into view because of the 3D and the depth there in robotic platforms. So whenever you start a RBC coming out, you will be catching it. So overall blood loss, definitely yes, robotic surgery less blood loss rather than a laparoscopic surgery. The reason being the quality of the platform only.
Secondly, sir, do you do ultra low LAR or do you prefer APR better than that because of the complication?
No. The one biggest benefit of robotic surgery is preserving the sphincter. I have done 9 cases of ultra low AR, ISRs also. Benefit is that preserving the sphincter. Robot plays a major role in that. Robot is not for hernia or gallbladder or appendix. Robot is for this thing. Deep pelvic surgeries and whatever thing that is done in the thorax, robot has a edge.
You still consider ultra-low LAR comparing to APR?
No, see, there are also principles. When there is a lesion that needs to be tackled only by APR to achieve margins, you have to do it that only. Whenever you have a well-differentiated lesion close to the anus where we have a doubt that whether we can preserve this or not, there you can decide upon doing an ultra-low AR. What I am trying to tell is ultra-low AR can be done easily using a robo.
Yes, that can be done, sir, but what about the quality of life, which is better, I'm asking, which maybe I think APR, doing an APR will have a better quality of life for comparing that ultra-low LAR one.
It depends upon patient's factor as well as the doability. If some patient is adamant enough to tell you that I want to preserve my anus, you have to tell him that in this particular situation we cannot do that. Then we have to send the patient to somebody else who is going to preserve the anus. For some patient it will be like borderline, where we can take a chance depending upon the disease as well as the patient's choice. In that patients we have to discuss in detail with the patient about the advantages, pros and cons of keeping this sphincter. Only when they understand the outcomes to the fullest extent, then you can try. All those things are basic principles that has got nothing to do with robo or lap.
Have you encountered any stapler misfiring, sir? If yes, how do you manage? Any stapler misfiring, doing circular stapler firing?
When you go for very cheaper staplers, it has happened. It has happened.
Because nowadays everywhere we use only Covidian staplers, sir. So that
no, not everywhere. You are a very costly surgeon, I suppose.
Not like that, sir. Even in GH we use the Covidian staplers only, sir.
No. I am also a GH surgeon. You should know. I was using Panther in all of my robotic cases. I have done it with Panther only because we are poor people, unlike you.
Not like that, sir.
TVMC, because of the SARS, Saravana Bhoopathi sir's ardent and diligent management, he could bring this to this level. We were working in small setups. Okay.
Thank you very much, sir.
Thank you. Bye-bye.
I request Professor Dr. Bennett sir to honor the speaker. I request Professor Dr. Prabhakaran sir to honor our chairpersons.
By the time Dean is arriving, anybody wanted to felicitate Dr. Saravana Bhoopathi can start.